Bismillahirrahmanirrahim. Assalamu alaikum. Let me start the talk. The first talk will be given by Dr. Faisal Azam, who's a medical oncologist, King Fahd Specialist Hospital, Dammam. And the topic is first-line metastatic renal cell carcinoma.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. So, and thank you very much for the introduction. Thank you for Shaukat Khanum to organize this meeting, and thank you for inviting me to talk about the first-line treatment of metastatic renal cell carcinoma. So I'll be talking about the options of treatment in first line for metastatic renal cell carcinoma. These are my disclosures, and this is the place where I work actually. So I'll show you a few pictures from the same place or same city. Right, so before I talk about the renal cell carcinoma, it's important to stratify the patient into favorable risk or unfavorable risk. And we usually or commonly use IMDC criteria. The reason for that is because treatment and prognosis differ. So for favorable risk disease, the survival is much better as compared to intermediate or poor risk disease. And if you look at the guidelines for favorable risk disease, the treatment options or preferred treatment options are to give VEGF TKI target therapy with one of the immunotherapeutic or immune checkpoint inhibitors. Combinations are currently recommended. But if you look at the poor intermediate risk, similarly, all these three combination, in addition to combination of immune checkpoint inhibitors, which is ipilimumab plus nivolumab, and cabozantinib is also one of the preferred treatments. So these are the treatment options which I'm going to discuss in detail now. So first-line treatment, we have been using sunitinib or pazopanib most commonly for almost a few decades actually, because these studies have shown to improve the progression-free survival. And then we have compared pazopanib with the sunitinib, and we said it's non-inferior. All these studies have shown to improve the progression-free survival, and that is the reason it was approved at that time. Then we have cabozantinib again from phase 2 study showing improvement in progression-free survival, and that progression-free survival was mostly seen in those patients who had a MET mutation positive disease. Things have now moved. Those were the era where we were approving drugs for metastatic renal cell carcinoma based on progression-free survival. But now we have combination of treatments, and it's showing overall survival benefit also. So Checkmate 214 has led to approval of ipilimumab plus nivolumab, which is a combination of immunotherapy plus immunotherapy, and then Keynote 426 pembrolizumab plus axitinib, Checkmate 9ER nivolumab plus cabozantinib, Keynote 581 pembrolizumab plus lenvatinib. All these are VEGF TKI plus immune checkpoint inhibitor. So if you look at the comparator arm, all of them have used sunitinib as a comparator arm because that was the standard of care at that time. And all of these studies have shown overall survival benefit. Then we have two other combinations. Ipilimumab plus axitinib showed progression-free survival, and it is approved. Then atezolizumab plus bevacizumab approved based on progression-free survival, but later on it was withdrawn because the overall survival benefit was not seen. So this combination is currently not recommended. So let's briefly discuss the evidence and the trial evidence we have. Pembrolizumab plus axitinib was approved because of the phase 3 study called Keynote 426. So patients who have newly diagnosed advanced or metastatic renal cell carcinoma were randomized to either pembrolizumab, IV, and axitinib oral versus sunitinib as a standard dose orally. Overall survival benefit, progression-free survival benefit in the ITT population was seen. Hazard ratio, you can see 0.68 for overall survival, 0.71 for progression-free survival. After 42 months of follow-up, the results are same. So for those, so this is for the overall survival, the hazard ratio remain favoring using pembrolizumab plus axitinib. 0.73 was the hazard ratio. Progression-free survival, similarly, 0.6 is the hazard ratio after 42 months of follow-up. The objective response rate of more than 60% with 10% complete responses when you use pembrolizumab plus axitinib, and the standard of care was sunitinib 39% with only 3% of complete responses seen. Then analysis in this study were done at 1 year, 16 months, 30 months, and 42 months. Overall survival, progression-free survival, and objective response rate over all these years has been remained the same. If you look at the hazard ratio for progression-free survival or overall survival, it remained same over the years. Objective response rate remained around 60%, which is a significant improvement from what we were talking about with single agent VEGF TKI. So now looking to the intermediate and poor risk disease, there was an overall survival benefit, progression-free survival benefit, and objective response rate benefit in favor of using combination of pembrolizumab plus axitinib versus sunitinib. Then when we look at the favorable risk group, there was objective response rate benefit of nearly 70%, 11% complete responses. Progression-free survival benefit was seen, but no overall survival benefit. So no overall survival benefit in favorable risk, but this progression-free survival and objective response rate benefit was seen in favorable, and that is the reason it's the preferred treatment even in the favorable risk group also. Toxicity-wise, between the two groups was not much. Grade 3 to grade 5 was seen in 13%, which is reasonable actually for combination treatment as compared to 2.4% with sunitinib. So current recommendation is to use pembrolizumab plus axitinib as a preferred treatment, first-line metastatic renal cell carcinoma for favorable risk or unfavorable risk like intermediate or poor risk disease. Second combination is nivolumab plus ipilimumab. Nivolumab is anti-PD-1 antibodies and ipilimumab is anti-CTLA-4 antibody. Both of these are immunotherapeutic agent or immune checkpoint inhibitors. So the randomization similarly were 4 cycles of ipilimumab plus nivolumab followed by maintenance nivolumab versus sunitinib as a comparator arm. The analysis at 17 months, 30 months, and 42 months all showing improvement in overall survival in patients who have intermediate or poor risk disease, favoring using ipilimumab plus nivolumab as compared to sunitinib. Overall survival in favorable risk disease, no benefit. Similar to other study, we are saying hazard ratio is 1.19. So if you use ipi plus nivo or sunitinib, there's no benefit of using ipi plus nivo. In fact, sunitinib would be a better option for these patients. Then looking at the objective response rate, so this is for intermediate and poor risk disease, this is for favorable risk disease. And you can see here, patient who had ipi plus nivo had a 42% objective response rate as compared to 26. But if you look at the favorable risk disease, the objective response rate is better with sunitinib as compared to combination. So no improvement in overall survival, no improvement in objective response rate in favorable risk disease. Then progression-free survival in intermediate and poor risk disease favoring using ipilimumab plus nivolumab hazard ratio of 0.76. And another important point to notice here is at 30th month, the progression-free survival curves plateaus, and it remains so. That means after 30th month, if the patient is progression-free, it will remain so. This is a big benefit of using immune checkpoint inhibitor combination. So this is in patients who have intermediate or poor risk disease. So how about favorable risk disease? No benefit. So you can see here hazard ratio 1.62. So when you're using a combination of immune checkpoint inhibitors, in favorable risk disease, there is no benefit of objective response rate, progression-free survival, and overall survival benefit. And that is why it is not currently recommended as a preferred treatment for favorable risk disease. Then quality of life of those patients who were on ipi plus nivo was much better than those patients who were on sunitinib. So current recommendation is to use this combination in intermediate or poor risk disease, but not in a favorable risk disease. Third trial is Checkmate 9ER, which led to approval of nivolumab plus cabozantinib. Nivolumab is an immune checkpoint inhibitor. Cabozantinib is VEGF TKI. Comparator arm, similarly, sunitinib. This trial has shown improvement in progression-free survival favoring nivo plus cabozantinib, hazard ratio 0.51. Now, this benefit of progression-free survival was seen regardless of the favorable risk disease, intermediate or poor risk disease. Overall survival benefit similarly was seen with combination as compared to sunitinib, hazard ratio of 0.60. Now this trial is a bit different. Here you can see here the overall survival benefit was seen even in favorable risk disease. So favorable risk disease, intermediate or poor risk disease. So all patients got benefit in terms of overall survival. Objective response rate 55.7% with 8% complete responses reported as compared to 27% with sunitinib. Now, after 33 months of follow-up, the results are exactly similar. Overall survival, progression-free survival, objective response rate are similar to the initial analysis. But another important point to notice is complete responses at initial analysis were 8%. Now it is 12.4%, so improving. Median duration of response, 23 months. Grade 3 toxicity was more or less similar to sunitinib or not much different. Then immune-related adverse event were pretty much rare, 1% or maybe less than 1% of grade 3 immune-related adverse event were noted. Quality of life, as like other studies, it has shown that those patients who had cabozantinib plus nivolumab, their quality of life was better than sunitinib. So checkmate 9ER has led to approval of cabozantinib plus nivolumab in first line because it has shown to improve overall survival in all groups of patients, progression-free survival and objective response rate, including the favorable risk disease also. Our last study is a CLEAR study which led to approval of lenvatinib plus pembrolizumab. Lenvatinib is a VEGF TKI, pembrolizumab is an immune checkpoint inhibitor. Second arm is lenvatinib plus everolimus. Everolimus is an old drug, mTOR inhibitor. And third arm is sunitinib. So progression-free survival, when they compared lenvatinib plus pembrolizumab with sunitinib, it was favoring combination with hazard ratio of 0.39. When they compared lenvatinib plus everolimus with sunitinib, hazard ratio also was favoring combination with the hazard ratio of 0.65. And this benefit of progression-free survival was seen in poor risk, intermediate risk, or favorable risk disease. Then overall survival, when they compared pembrolizumab plus lenvatinib with sunitinib, the hazard ratio was 0.66. But when they compared lenvatinib plus everolimus with sunitinib, there was no benefit. So currently, this combination is also not recommended to be used in first line. Overall survival benefit was seen in poor risk, intermediate risk, but not in favorable risk disease. So a repeated sort of thing when you use VEGF TKI plus immune checkpoint inhibitor, especially when you're using pembrolizumab in favorable risk disease, you don't see benefit in terms of overall survival. The best part of the results or outcome is this one. So with lenvatinib plus pembrolizumab, objective response rate of 71%. This has never been known before that. Complete responses of 16%. This is amazing, actually. These results were never been reported before this study. And that is why I usually prefer this combination in those patients who are symptomatic, who have a high volume disease. And I have quite a few patients on this study, and they respond really, really well. So currently, lenvatinib plus pembrolizumab is recommended as a preferred treatment in first line in all risk groups, although there was no overall survival benefit in the favorable risk disease. So we have four combination. Either we use immune checkpoint inhibitor combination, or we use VEGF TKI with one of the immune checkpoint inhibitor. So which one would you give if you have all the options? So I have a few slides on that, how, so just taking the data from these studies. Now, this is not the direct comparison. These are just the numbers taken from the studies. This is 12 months overall survival, and this is 24 months overall survival. Looking at these different studies, so Nivo plus Ipi, Pembro plus Xi, Nivo plus cabozantinib, Pembro plus lenvatinib. And if you look at the overall survival, 12 months or 24 months, so combination is definitely better than single agent sunitinib. So currently, do not use single agent if you can use combination, because now we have very good evidence to use the combination. But which combination would you use is the basic question. And if you look at the VEGF TKI plus immune checkpoint inhibitor, especially the one which used pembrolizumab, look at the overall survival, 91%, 90%, so significantly higher. But when you use Ipi plus Nivo, immune checkpoint inhibitor combination, It's slightly less, but this is not direct comparison. These are just the numbers. Similar results are seen at 24 months also. Again, overall survival, when you look at the all these four combinations, overall survival benefit has been reported. If you look at the intermediate and poor risk disease, overall survival benefit has been seen. If you look at the favorable risk disease, then except nivolumab, sorry, where is that? Yeah, nivolumab plus cabozantinib, which has shown to improve the overall survival in favorable risk disease. All other combination did not show to improve the overall survival in the favorable risk disease. How about the toxicity among all these drugs? So I personally prefer this drug, as I mentioned, or this combination for those patients who have a high volume disease, who are symptomatic. But look at the toxicity. Grade 3 to grade 5 toxicity of 82%. So although it has significantly higher objective response rate of more than 70%, but at the cost of this toxicity. Then pembrolizumab plus axitinib, 67% grade 3, grade 5. Nivolumab plus cabozantinib, 62%. Immune checkpoint inhibitor combination, 48%, much better as compared to this. Then discontinuation of the treatment was high, more in those patients who use VEGF TKI with immunotherapy because of the toxicity, which is understandable. So for intermediate and poor risk disease, we have all the combination, VEGF TKI with one of the immune checkpoint inhibitor or combination of immune checkpoint inhibitors. So which combination is better for those patients who have intermediate or poor risk disease? If you are using IPI plus Nivo, there's lower toxicity, better quality of life, durable but slow responses. I showed you that those patients who have progression-free at 30th months, most probably their curves plateaus, and most probably they remain so for a longer period. So those patients who have a low volume disease, who have less symptoms, I usually prefer to give IPI plus Nivo for this reason to these patients. TKI with immune checkpoint inhibitor combination, which are 3 different combinations currently approved, higher and rapid objective response rate. And that's why I said I use it in those patients who have high volume disease, are more symptomatic, but you need to take care of that. Higher toxicity and significantly higher toxicity has been reported. So IO combination, we said, have good overall survival, progression-free survival, objective response rate, but not in the favorable risk disease. This is for intermediate and poor risk disease. IO TKI currently recommended for all risk disease. 12 months, 24 months overall survival, objective response rate with IO TKI combination in trial have shown to be better than IO combination, and specifically those which use pembrolizumab plus lenvatinib, pembrolizumab plus axitinib have shown significant improvement in 12 months and 24-month overall survival. Then there is a group of patients it's just worth mentioning. Patients who have sarcomatoid features on pathology, they usually have a very poor prognosis. And I just extrapolated data from all these studies, and it seems like when you use IPI plus Nivo, that is IO combination, they seems to be doing better. So maybe for the patient who have sarcomatoid features, it might be the better combination. But again, this is not the direct comparison. I'm just taking figures from all these studies. So what's new? What are we doing further? We have dual therapies, which is better than single therapy. Now we are trying to give triple therapy. And this was presented only last month in ESMO. I was there when they presented this. Cabozantinib is VEGF TKI, Nivo plus ipilimumab IO combination has been tested against IPI plus Nivo IO combination. So this study has shown to improve the progression-free survival, not significantly higher, but slightly. Objective response rate, again, not much difference, but there was some improvement, but significantly higher toxicity when you use triplet therapy as compared to doublet therapy. And there's no overall survival benefit seen so far. So we are waiting for the overall survival data, but currently, because of the higher toxicity and the progression-free survival, objective response rate are not significantly different than doublet therapy. So it is currently not recommended, but maybe in the future, that might be one of the options we have. So this is my last slide. So what are the current recommendations for favorable risk disease? Do not use IPI plus Nivo. IO plus IO combination is not recommended because I've shown you the data, no overall survival benefit, no progression-free survival benefit, no objective response rate benefit. But when you use VEGF-TKI with one of the immunotherapy drugs, pembrolizumab plus axitinib, pembrolizumab plus lenvatinib, or cabozantinib plus nivolumab, they all can be used. These two studies have shown no overall survival benefit in patients with favorable risk disease, but objective response rate was significantly higher, progression-free survival was significantly higher. Cabozantinib plus nivolumab even have shown to improve the overall survival in the favorable risk disease. Intermediate or poor risk disease, the all combinations have shown to improve the overall survival, progression-free survival, and objective response rate. So all these combinations can be used. Personally, as I mentioned, those patients who have a high volume disease, who are more symptomatic, I would prefer to give VEGF-TKI with immune checkpoint inhibitors, specifically pembrolizumab plus lenvatinib, as the objective response rate was 71%, complete responses of 16%. Those who have more indolent disease or low volume disease, I prefer to give AP plus Nivo in intermediate or poor risk disease because it is really less toxic. I have never seen any major toxicity in patient who in the renal cell carcinoma. I do melanoma also. Melanoma is toxic because we use higher dose of ipilimumab. But for renal cell carcinoma, the toxicity is much less and quality of life is much better. Thank you very much.
Thank you very much, Dr. Osman, for offering me the mic, and thank you very much, Dr. Faisal, for a very elaborate presentation, though we are 11 minutes behind from our schedule. However, thank you very much for being on time, and you took exactly your 20 minutes. I think we can take few questions from the audience if they have any, or otherwise, we'll move on to the next session. Yes. Yeah.
So there are different thoughts. Very well taken about the starting point. It's very useful. What do you think about the capillary gap? Which option or combination?
Right. So for the non-clear cell carcinoma, actually, we don't have much evidence of what to give, but current recommendation is to use the single agent VEGF-TKI. So cabozantinib is my preferred treatment option I usually give. But of course, you can give EP plus Nivo also. But the best evidence so far is to give single agent VEGF-TKI.
Yeah. Thank you very much, Faisal. Yes. I would like to invite our next speaker, Professor Syed Hussain, who will be talking on changing landscape in the management of advanced metastatic urothelial cancer. Thank you very much, Dr. Hussain. Yeah, you can start, please.
Assalamu alaikum. Thank you very much for inviting me for this symposium. It's always a great pleasure to be in Pakistan and to meet our wonderful colleagues here and talk about opportunities of collaboration for future. I think what I'm going to do in the next 20 minutes is give you a flavor for how bladder cancer is completely transformed over the last 10 years. And that I will try to do in 20 minutes. These are my disclosures. I think one thing which I want to mention, I've spoken to some of the colleagues here already. I think one of the key things which I've set it up in Sheffield, I did it in Liverpool as well when I was there, setting up a joint uro-oncology clinic where a urologist and oncologist are doing clinics in parallel to each other and where patients can flow from one side to the other on the same day. That helps to improve clinical trials recruitment, which I've seen again and again in our clinical practices. And that helps to improve clinical trial opportunities for our patients as well. And that is something we'll talk about with colleagues in Pakistan and other areas as well, offline after the meeting today as well. If you look at the first line clinical trial and sort of the data, it was very depressing, really. A few years ago, what we're seeing is that gemcitabine and cisplatin versus MVAC, the median survival is 14, 15 months in first-line setting. And that held on for over 20 to 30 years since it has been challenged more recently, and we are seeing better outcomes for these patients. Similarly, for the cisplatin ineligible patients, the depressing figure of median survival was about 9 months. And that again held true till about a few years ago when immune checkpoint inhibitors and other combination treatments, including conjugate antibodies, are challenging those figures and improving the outcomes for our patients. So this was the data, 14 months versus 15 months. You can see there's no difference between GemCis versus MVAC in that sense. The difference was in toxicity, and that helped us to change the sort of our standard of care from MVAC to gemcitabine cisplatin, because there was significant amount of mucositis, 21.9% in MVAC arm. Similarly, neutropenic infections, 15.1% versus 2.5%. That led to significant hospital admissions. So if you look at the inpatient bed days, that was significantly less with GemCis, about 34 days versus over 200 days with MVAC chemotherapy. So the whole reason that we have moved from MVAC to GC was not based on efficacy improvement, but was based on better toxicity profile. Paclitaxel plus gemcitabine cisplatin has been used. Again, not significant differences, 12.8 versus 15.7 months with hazard ratio of 0.85. Dose-dense MVAC has been used. Again, if you look at the median survival, 15.1 months versus 14.9 months. But again, you do see it requires very careful patient selection, but patients who do tolerate it in a way with GCSF support and all that, they can have a better outcome in terms of long-term disease control and survival. But again, the data is in terms of toxicity profile and efficacy, it is not something that is routinely used nationally and internationally. Cisplatin ineligible is an interesting patient group, because if you look in our clinical practices, almost 1/3 of the patients will be cis ineligible based on impaired renal functions, based on performance status, heart failure issues, peripheral neuropathy, presence of solitary kidney, and other factors that include some combination of comorbidities. And again, this is something that we have worked quite a long time in terms of improving outcome for this group of patients who we talked about, cis ineligible patients. Till just a while ago, the median survival was about 9 months. And that is the figure we need to challenge. I was delighted to meet some of the fellows from Shaukat Khanum yesterday. And again, knowing about how many people are using different regimens like cisplatin ineligible patients, where we're using a split dose cisplatin. And that is something I'm hoping will come out from Shaukat Khanum, and hopefully we can add other centers like PKLI and other places as well. This was some work we did many years ago, which was part of my doctorate, is splitting the dose of cisplatin, which I'm delighted to see is being used nationally in UK, but also internationally in North America and many parts of the Europe, Asia, and Middle East. And this was based on using the same dose of cisplatin, 70 milligram per meter square, but splitting it into day 1 and day 8, which led us to see that actually renal functions were not compromised, but actually started to improve as you got those cisplatin in, tumor regressed, that helped to improve renal functions. And that slide here telling about renal functions, we are seeing patients, if you focus on the GFR between 40 to 60, you can see that this group as well, the renal function is not dipping down below 40, but actually either steadying or improving. And I think that was interesting to see. Further on, as I said, 9.3 months, 8 months. So this was the picture that before the advent of immune checkpoint inhibitors, that's what we were seeing before. And then advent of immune checkpoint inhibitors. For the first time, we started to see with the use of atezolizumab and pembrolizumab, median survival started to move around 15 months and 14 months. So that was in first line setting in cisplatin ineligible patients with the use of immune checkpoint inhibitors. More 3 years ago then, with the use of immune checkpoint inhibitors, based on some of the clinical trial data, you have to have PDL positivity status. Patients have to be PDL positive to use first-line immune checkpoint inhibitor in these patient groups. In terms of neoadjuvant trials, these are more recent trials. Abacus by Tom Powell, which used atezolizumab in muscle-invasive bladder cancer. A small phase 2 study, single-arm study, went in Nature Medicine based on a lot of exciting translational work which was done. We showed that transforming growth factor beta and fibroblast activation were linked to resistance. And I think this was quite a key thing to look at, that a single-arm 95-patient study went into Nature Medicine based on a strong translational work. And that is something we really need to look at. Pure-01 with my colleague Andrea Necci with pembrolizumab in muscle-invasive bladder cancer, again showing with PDL positive patients quite interesting results in terms of the outcome, PAT-CR rate 42% overall in all patient groups, but there was PDL positive and high tumor mutational burden did improve response. NeoBlade trial, which we published in Lancet Oncology more recently, that was looking at nintedanib, which is a VEGF-FGF inhibitor, and by combining that, so this was a randomized placebo-controlled trial, gemcitabine cisplatin plus nintedanib versus gemcitabine plus cisplatin plus placebo. And that trial showed there was no improvement in the primary endpoint of pathological complete response, but there was significant improvement in overall survival at 2 years, which was quite exciting to see. In terms of neoadjuvant trial, there are a number of combinations going on that are looking at nivolumab in combination of chemotherapy, atezolizumab in combination with chemotherapy, durvalumab in combination with chemotherapy. So the results have not read out, but those will be interesting trials to see what is the toxicity profile for these cases when you're adding immune checkpoint inhibitor earlier on in the disease setting. Similarly, in cisplatin ineligible patient groups, there are significant amount of trials going on as well. With IO, as I mentioned, Niagara trial is going to be quite important. The readout will be soon. The trial recruited its last patient last year. And I think similarly with Energize, which is looking at the combination with nivolumab and followed by adjuvant treatment as well. In terms of adjuvant immunotherapy, I think it's important to look at Checkmate 274 data, which was a phase 3 randomized double-blind multi-center study of adjuvant nivolumab. Quite an interesting trial, 700 patients, nivolumab versus placebo after having either the patients have had neoadjuvant chemotherapy followed by persistent high-risk muscle invasive disease, or patients had no neoadjuvant chemotherapy. In that case, they had to have PT3 or more disease or N1 disease, that is node positive disease. So that was the trial. What was very clear was that in terms of intention to treat population, hazard ratio of 0.70 with a significant improvement in nivolumab arm, 21 months versus 10.9 months. So almost doubling of the progression-free survival in PDL positive patient population, that with hazard ratio of 0.53. So almost halving the risk of disease recurrence in that group. And that's quite an important step. You're bringing these treatments forward. I'm delighted to say that NICE approved that drug in UK. So it is available for our patients if they are PDL positive and they've got persistent muscle invasive disease. So a lot of the debate we had, I was representing the oncology team at NICE, and the questions, because it's always looked at with the cost as well, the cost that these drugs have. But I think toxicity profile favored that actually we were not seeing any compromise in terms of toxicity, extra toxicity, and the progression-free survival almost doubling. So in UK, NICE approved it only for PDL positive patient population. They have not approved for all patient population. But I think with more PFS OS data coming through, we may see that change as well. IMvigor010 is important to mention about because this is a similar drug called atezolizumab, but that trial was a negative trial. Again, there was no placebo in that. It was versus observation. And that trial showed that actually there was no significant difference in between the two arms, where you can see 19 months versus 16.6 months. What is very interesting to point out here is that if you look at the observation arm here, 16.6 months versus the placebo arm in nivolumab arm was 10.9 months. So the difference is mainly in the observation arm or placebo arm. The median progression-free survival in atezolizumab is 19.4 months and was 21 months in nivolumab, which is difficult to explain. One reason will be because it is a progression-free survival event, which is looked at through the CT scans. Interim overall survival as well did not show any difference between atezolizumab and observation arm. Similarly, for PDL positive patient population as well, there was no significant difference between the two arms. In terms of advanced bladder cancer coming to first line, second line setting, it's important to realize that actually how these immune checkpoint inhibitors and what are the different pathways and mechanisms on which they are working and making an impact for all these patients. This immune checkpoint inhibitors have literally transformed oncology over the last 5 years, and it is being used all across the globe. It's important to look at those toxicities very carefully as well. But just to give you some data, this is something some years ago we published in Lancet, and that was a phase 3 randomized trial looking at atezolizumab versus standard of care chemotherapy, which was a dealer's choice. You can use vinflunine, docetaxel, or paclitaxel, and the data was very clearly showing that for the primary endpoint, which was looking at for PDL positive patient population. So this was one of the largest trial, 931 patients who went into the trial in second line setting, but PDL positive patients were about 234 patients. And within that group of patients, you can see there was little difference. So if they are PDL positive, the difference is that PDL positivity perhaps choose it for prognosis. It's more like a prognostic biomarker, not a predictive biomarker. So we learned from this trial that it was wrong for us to put the eggs in the basket of PDL positivity, because over the years we have learned that PDL is just one of the biomarkers. PDL positivity, CD8 infiltration, tumor mutational burden, they all contribute to it. So perhaps it's a combination of these factors which make an impact on that. You can't choose it on that basis. But prognosis, you can see 11.1 months versus 10.6 months. So irrespective of the treatment you receive, the key thing is that you are improving survival based on PDL positivity. So that was important observation, that PDL positive patients do better in that sort of a setting. ITT population as well, 8.6 months versus 8 months. That is what we see with, again, hazard ratio of 0.85. NICE did approve that drug as well on that basis. And the primary endpoint of overall survival was not met in the IC23 patient population, but there were more patients with significantly more long-term durable responses. You know, I have recently submitted data for ASCO GU with 55 patients data, one of the largest numbers in UK. We've treated over 2 years with atezolizumab, and almost 18 out of those 55 patients are still alive, having had been treated for over 18 months and 24 months. So you're seeing a subgroup of patients who are doing well and alive for a long period of time. And there was no safety signals as well in that trial. We did not see any significant toxicity that came out. So there was no additional safety issues that came out of that. Similarly, with pembrolizumab, second line, we saw median survival of 10.3 months versus 7.4 months. In view of those, second line immune checkpoint inhibitors are available as well. Moving on to conjugate antibodies, and I do want to say that here, that even in UK, we don't have access to conjugate antibodies. And that is something that me and Nadeem Nusrat, when we talk about in PKLI MDT, we really want more trials to open in this country. And we have got patient population here. So if we all work together, make it a very sort of a robust discussion and say it more on a Pakistan basis, that in Pakistan, we have got these 2, 3, 4 sites who will do these trials. I can tell you industries will have appetite to come over here because they want patients to be recruited quickly. So that is one thing which is very close to my heart. And I'm very happy to speak to my colleagues around here about that. So conjugate antibodies, the reason I'm saying even in Sheffield, I tried my best to get conjugate antibody trials open here. And that helps us to get some of these drugs over to our patients, because otherwise we can't afford it, as simple as that with NICE, because based on that, we don't even go to NICE. So EV201, again, primary endpoint, looking at pivotal phase 2 trial, looking at cohort 1 PDL1 inhibitor versus patients who had previously been treated. Again, in third line setting, so patient had chemotherapy, immune checkpoint inhibitors, and then you are seeing a median survival of 11.7 months. So these are important figures that we are talking here about third line and fourth line patients who are having a median survival of 11.7 months and progression-free survival of 5.8 months. And this was the 301 global multi-center phase 3 trial that basically confirmed EV201 data and very clearly showed that there was significant improvement when we look at the arm of the enfortumab vedotin conjugate antibody with a median survival of 12.58 months versus 8.97 months with chemo. So coming to patients who had platinum-based chemotherapy, who had immune checkpoint inhibitors, and moving on to third line to have a median survival. So remember my first slide where we talked about a median survival of 11, 12 months in first line setting, 14 months in first line setting. Here we are talking about third line and fourth line setting into 13 months. This was combination chemotherapy with Enrique Grande presented a while ago, adding chemotherapy with immune checkpoint inhibitors. Not a significant difference. We can see here progression-free survival endpoint was met. The only thing where we could see in the forest plot was that patients who were given platinum, they were having significantly better in terms of combination of immunotherapy plus chemotherapy regimen. So atezo plus platinum gem, again, we can see they're well sort of balanced in those factors, but overall progression-free survival endpoint was met with a p-value of 0.82, p-value of 0.007 and hazard ratio of 0.82. But again, the key thing is that 6.3 months versus 8.2 months. But again, we don't have, in terms of the median survival is key here, which we are awaiting. Safety signals, again, combining chemotherapy with immunotherapy. Again, we are finding it is reasonably safe. We can deliver it safely without causing significant toxicity or major morbidities to patients. Danube was another trial using combination with durvalumab, and again, 14.4 months versus 12.1 months, hazard ratio of 0.89 with p-value 0.303. But if you look at durvalumab plus tremelimumab, that was the only group that was looking to be doing better with 15.1 months versus 12.1 months. Maintenance avelumab is one of the key trials which has recently been reported, and I'm delighted to say that it has come into standard of care now. In UK as well, NICE has approved the use of maintenance avelumab based on the Javelin 100 trial. Very clear, important trial. 700 patients went into the trial, and what it very clearly showed, the median survival of 21.4 months. And again, I represented the UK oncology and patients in terms of the to NICE. And initially it was pushed back. They gave a negative appraisal. What was key here, the point we made was that this median survival of 21.4 months is from the time of randomization, is not from the time of starting chemotherapy. So you had 4 to 6 cycles of chemotherapy, which will mean 12 to 18 weeks of treatment, followed by 4 to 10 weeks of screening process for randomization. So you're talking here, this is the first study that is telling that patients with advanced metastatic bladder cancer are living more than 2 years. And that's a landmark figure we have achieved, over 2 years of survival. So 21.4 months, I can tell you another data which has not yet been published, but will be published in the next few months, which is showing the median survival is actually 23.8 months in the avelumab plus best supportive care arm. And that is from randomization. So it's not from the start of chemotherapy. So you can easily add another 4 months into it. So this is really exciting. Metastatic bladder cancer is turning the corner. We used to call it a Cinderella cancer, which is now turning the corner. Overall survival, as we said, 14 point, and then overall survival in PDL positive population is for avelumab has not yet been reached, and best supportive care is 17 months. So this is basically available for patients, for all patients, irrespective of their PDL1 status. PFS again was significantly better, 3.7 months versus 2.0 months. And in the PDL positive population, it was 5.7 months. So better PFS in that group. Immune-related adverse events, there were no significant new safety issues that came out. EV302, I just wanted to mention about EV plus pembrolizumab in first-line setting versus GEM plus CIS. That trial will be reading out soon. And we expect that data to come out at ASCO or ESMO next year. So again, that will be interesting, that without chemotherapy arm, what is the outcome in these patients group? I think this is something which I just want to talk in the end, window of opportunity trials. Many of the colleagues are, we have talked offline about it, and these are the trials that we can do. You need a good, strong uro-oncology and multidisciplinary team, pathology, and other colleagues to work together in this sort of a setting. I've talked to quite a few colleagues who are representing other parts of the world as well to talk about that these are trials which are sort of low-hanging fruits. If you've got a good multidisciplinary team, you can really do these trials. Primary endpoint must be well-defined, and multidisciplinary teamwork is key. We got a study funded by Roche, 1.5 million pounds that myself and Jim Cato are leading on. And again, the key thing here is that the reason to mention it here is that you are a strong team together here, oncologist, urologist, and other multi-pathologists. If you all work together here on a more national basis, we can do these sort of trials here. So what we're doing is that we're using first in human intravesical atezolizumab for patients who are undergoing cystectomy in any way. So cystectomy has been chosen. In UK, I know sometimes Nadeem, when we are in the PKLI, he says we're taking his bladder out next week. We take 6 to 8 weeks to take the bladder out. This is our waiting time, 6 weeks. So that 6 weeks I'm using to give intravesical weekly atezolizumab, first in human study, then the bladder comes out. The key thing is that the translational data that we'll get from that. So patients who do not respond. So there will be some patients who have muscle invasive bladder cancer who do not want neoadjuvant chemo, or who are cisplatin ineligible. So with me and Jim working together very closely, as I said about the joint clinic where patients flow between us, this was a great model to get these sort of studies. So we got this trial already funded, which has gone to MHRA and ethics, which we'll be getting soon. It will be a single center study. We have got Glasgow and a couple other centers who are on the standby if we need them, but we do 120 cystectomies a year. So we're expecting that we can do it in 18 months to 24 months within as a single center. But we have got 2 more sites who are keen to join us if required. This is another one that has been funded now. It's a big international study now, which I started with to be led by UK, but now we've got Guillermo from Spain and Renacci from Italy and Johan from France all joined together to do a big multinational international study, a similar patient group, but who are cis ineligible, but they are FGF positive, biomarker positive patients. So it's a biomarker driven trial where patients will get either erdafitinib, which is a FGF inhibitor, or erdafitinib plus citralimab. Again, for patients who are ineligible for platinum-based chemotherapy, and with FGFR alterations, that's the key. So this is my last one to look at cisplatin eligible versus ineligible group. You've got chemotherapy, you've got adjuvant nivolumab, maintenance avelumab, And then enfortumab, EV, a lot of these things are not, we need to think about clinical trials again from oncology point of view as well, Maria, as we talked about yesterday. It is important to think about how we can use and improve, get access to our patients by doing clinical trials. So key thing will be to get more data out from Shaukat, Khanum, PKLI, Yahya Khan, for other places to see that actually what happens in Pakistan, what is the number of patient population. That is what will attract industries to actually put more resources into our centers to get more of these trials open here. And again, EV, again, in platinum ineligible groups, as platinum ineligible patients, I do use split doses platinum. I'm expecting one of the abstracts will come out. Some of the fellows who are sitting behind today, they met yesterday, and we're hoping to get some of that data out for next year, ASCO or ASCO GU. And I think that's just the last one to say. This was a big, during our COVID phase, photograph taken. But what I'm saying, we started, I had another picture, which for some reason hasn't come up. We started with 2 or 3 people in the picture, and then the picture is growing. So this is the key thing, that people are seeing the benefit of it. We're setting it up. More and more multidisciplinary people are joining in that team, and we're getting all that work. So on that note, I will say thank you, and very happy to take any questions either now or later on.
Any questions?
Nice overview, for bladder cancer treatment. Just a question or comment, you can call it. So you are doing a trial, phase 1, phase 2 trial for FGFR. We have a phase 2 evidence, good evidence actually. We're currently using this standard of care, to be honest, in Kingdom. Second is, you did not mention sacituzumab, to be taken as an antibody drug conjugate, but you are more in favor of going for vedotin, although the price of sacituzumab is much cheaper. Yeah. So I'm personally, I'm saying this because I have tried to apply to approve in our center. They refused it because the price, and vedotin was too expensive, but they approved sacituzumab. So maybe that's, if you are planning to do trial, especially in Pakistan, that's another option because the studies are possible.
Yeah, no, I completely take your point. It's a very good point. The key thing is that sacituzumab, as you know, the data is following enfortumab. So enfortumab, we've got phase 2, phase 3 trial data evidence for sacituzumab. So we have opened a trial, Trophy-01, which is looking at phase 1 trial of adding and combining things with sacituzumab. So in UK, we are getting these drugs through clinical trials. So any EV trial or sacituzumab trial, I'm opening up over there. So that's how we.
No more questions. Thank you, Professor Hussain, for such a nice talk. The next talk is going to be given by Dr. Nadeem Pervez, who's a radiation oncologist at Sultan Qaboos Cancer Center, Muscat, Oman. He's going to talk about cutting-edge radiotherapy innovations in the management of prostate cancer. Dr. Nadeem Pervez.
Assalamu alaikum. Bismillahirrahmanirrahim. Okay, appear screen picture. Thank you very much for the organizing committee to give me an opportunity to talk to great people here. And since I'm here, I met actually good few friends here. So that was the big gain for me since last night. So here I'll be talking about a few messages basically. There are lots of things which are moving in radiation oncology, but of course, for the 20-minute sake of time, I will be only talking about 3 main topics. To start with, I was waiting for if one of my colleagues will talk about prostate cancer somewhere and say this slide staging so I can move forward quickly. But anyway, for the prostate cancer, when we do stage them, we utilize the PSA very commonly. Digital rectal examination, I'm writing it, but very few people are doing it in the Middle Eastern region where I'm working. And the CT and MRI scan or bone scan was traditionally used investigation, but now more and more commonly, wherever it is available, PSMA, PET CT, we are utilizing. In our center, it's available. So that's what, when we do that, we don't need to do the bone scan or a CT scan, but we do the MRI scan. Still, there is an advantage of doing that. So with all this combination, when we combine all this staging investigation, we actually divide them into either localized prostate cancer or to metastatic or locally advanced. So when we say localized prostate cancer, they divide into 3 risk group: low risk, intermediate risk, and high risk. And the intermediate again can be divided into low and high tier. That's based on the combination of one of the 3, either T staging, Gleason score, and PSA. So without going into the detail of it, we all know about low risk, intermediate, and high risk. And then metastatic can be either regional lymph node involvement or metastatic disease, which is further divided nowadays very commonly into oligometastasis or low burden or to the high burden disease. So there are multiple definitions for all of them. I chose one of them. So more importantly, I want to talk to the treatment options for them. So when it is low risk, active surveillance is always an option. It is less commonly used though, because when you offer the patient, it is a kind of a short-term option they adopt. Initially, if they adopt, they usually change their mind later on for the reason because they feel like they're living with cancer and they're worried about it. But this is a quite valid option. It doesn't mean no treatment. It means only to defer the treatment for a time period when you need it. So we did some study in Canada and we found that active surveillance was quite valid for 80% of the people, but about 20% patient they actually were progress in a rapid stage than the active surveillance can catch. So the radical interventions are these ones for localized prostate cancer. So radical prostatectomy is always an option, even up to the selected high risk group, but for low risk and intermediate risk, it's there. Brachytherapy seed implant in prostate cancer, not available in our region, but we are going to start in Muscat, inshallah. After going from here, we will do the first case on 9th of November. Inshallah, we'll announce that as well. So this is an alternative option. And then external beam radiation treatment is always there. So more commonly practiced is radical prostatectomy and external beam radiation. However, brachytherapy is a good option, which is already established over many years in North America or Europe. And then the combination of all of this is there. External beam as initial phase, and then boost additional by high dose rate brachytherapy or low dose brachytherapy. I'll talk a little bit about that. And hormone treatment, depending on the which stage and what are the benefit, we can always add short course of hormone treatment here. For high risk, most commonly used is external beam radiation radical treatment with hormone therapy. But now after SNRT trial in Canada, then brachytherapy, seed implant, LDR is an option, and also high dose rate brachytherapy is an option. In selected cases, as I mentioned, the surgery can be an option as well. Now for the metastatic disease, we're dividing them more and more because before one of my supervisors during my residency in Ireland told me one horse has left the barn and he caught that whenever prostate cancer go out of the capsule, it is finish of the story and it would never be cured. So I wasn't agreeing as a resident. Anyway, now more and more evidence there that actually the patient can be even cured after that. So node positive is a regional disease, but it's called stage 4 disease. So that's for the regional node, but also the metastatic disease if they are not high burden disease, because radiation was utilized for those patients only for palliative purpose. But now we know more and more that if we target them early with higher doses, and with the advancement of this SBRT technique, we actually have opportunity to deliver the curative amount of radiation doses. And many of the patients have shown at least progression-free survival benefit, and some of them are longer-term survival. So anyway, I took quite a bit of time on this one, but my main topic will be, I'll talk about low-dose brachytherapy seed implant in early stages of prostate cancer. And mainly this is a monotherapy. So this is one setup treatment. So it's important for our patient as an option. It is not the only option, but is one of the options. And I will explain you why I would prefer this option over some other for early stages. Then I would talk about moderate hypofractionation in high-risk prostate cancer. That high-risk prostate cancer was treated longer duration, now can be treated in shorter time with similar outcome. So this is one of the topic I'll talk about. And then the study which we initiated, fortunately, I got the opportunity in Canada to initiate those trials in the beginning. So now there are more and more evidence, and it's now announced as an alternative standard treatment, ASTRO, this year, 2022. And then very little bit about stereotactic body radiation, SPR treatment, because this is still emerging field. People are using, but still emerging. What I skip is the ultra hypofractionation radiation treatment, which is mostly in the low and intermediate risk. However, the studies are going to publish soon, randomized trials, and that would be it's a common use now in some centers, but still there is evidence need to build as a randomized evidence. So LDR brachytherapy. So this, so I will explain that what LDR brachytherapy is. So it is used for monotherapy as one treatment option, one-time treatment option. Salvage therapy, when we give external beam radiation in prostate cancer early stages, and if they fail after that, focally only in prostate gland and not elsewhere, and then that time we can use as a salvage therapy. And the boost treatment, that after we give external radiation, we can add extra doses radiation to the prostate. So by using the boost treatment. So what does it implicate? Like last 7 years, I was trying to establish this option in the Middle East. It was very challenging. I was running around different center to center, and finally we got it, and we're going to start. So it does need actually this BK ultrasound system, which used for many other purposes, transrectal ultrasound system. We need this stepper where this system can place template which guide us for putting the seats in. Patient would be in lithotomy position, so we can either under GA or spinal. In the operating room, we do first assess with this transrectal ultrasound. This patient take the images of the prostate in this screen. And after capturing all those images, we do planned rate. So this will be the first step. So there are centers who do in one step everything or in 2 steps. So the way I did mostly, and what we're going to do is that we did first step, that we took the ultrasound images, capture it, plan radiation, order the seed, which is going to come from the US. And after the seed comes, then we implant in the operating room. So I'm doing in 2 steps at the moment. It could be done all in one time, but take a little bit longer. So after doing that all process, we get the seeds in this form. They are like needle, and the seeds are radioactive iodine 125 seeds are inside there, which have half-life of about 60 days. And then we insert in transperineally to the prostate gland by watching on the screen. For all this whole process is 1.5 hours for implant of the seed. But the before implant is about half an hour for the assessment and capturing the images. So altogether 2-hour procedure, and then it's a half-day procedure and patient can go home. So there are people who are not even ready, who are not radiation oncologists here, and they may look into these images just to explain them. These are ultrasound images, transrectal. So rectum is here. Red one is the prostate. Urethra is here, if you see in the very middle. So what we did actually, this is a patient which I did in Canada before I left. So this is showing that prostate gland size about 42 cc, this red one. When we grow some margin around, because we want to cover some of the healthy tissue around, so it become 55 cc. So we took these images first on ultrasound, and then after drawing, we place the seats hypothetical position, that where they should be and how much radiation will go. And these lighter color are radiation isoroses. So this is one of the advantage of brachytherapy, that radiation is not going from outside to inside and covering more of the normal tissue. It is placed inside the prostate gland permanently. We don't have to remove it back because it decay on the time, and the metal titanium just stay inside. And this radiation will fall off very quickly. So then the organ around like bladder or rectum will get less radiation compared to external beam. And this is the arch of bone. When we do transperineal, we don't want bone to be on the way to the prostate seed implant. So this is a 3D view of the same plan which I showed you. So rectum, prostate, urethra. So we avoid urethra and we put the seeds around. And after we do the implant, then we take another CT scan to check that what we generated a plan beforehand, did we accomplish that or not? So here is the same patient when we do the CT when we do the prostate gland and draw the urethra and we check the seeds, it is not exactly what we planned before. It is a little bit different plan, but is acceptable coverage for the prostate. So that's the QA process. And in 10 years, when I did in Canada, many patients we did. One time I missed some of the prostate where I have to go back and put some extra seeds. So that's also salvageable if that happened for some patient. So why would we do the seed implant over some other options when the other options are easily available and can be used? So these are advantage and some disadvantage of the seed implant. So it's a day procedure instead of coming many times to the center. Cancer control is at least equivalent, if not better. Good side effect profile. Many patients have the challenge of sexual dysfunction, and the claim from radiation oncologists is that the best erectile protection is by this procedure. It's cost effective. If you look into the cost overall for the brachy, is cheaper than external beam radiation. These machines we bought for a fraction of the price of the machine we use for external beam. The other thing is this minor procedure, very little bit of blood loss. Is just like a pink needle you prick 20 to 25 times to a patient. And that's even when the patient is sleeping or numb. It's a mobile unit. You can go take this from one center to other center, the ultrasound system. So whole setup can move around. But still there are some disadvantages that there are not many radiation oncologists who are interested in this procedure. You have to do about a year of fellowship to train yourself and then mentorship by someone. So it takes time and the medical expertise are not so many in radiation field. Then seeds sometimes may move. It doesn't harm though, with my experience, but it can move around. It can be stuck in the lung, and when someone do a chest X-ray, will find a metal piece there and be worried about, but it doesn't affect anything. There are my feeling is from external beam radiation, urinary symptoms are slightly higher in brachytherapy, even though compensated by the rectal toxicity less. It is not for everyone. It's for early stages and for the patient who have decent size of the gland and their bones are not on the way to implant, and urethra is very straight one. We do need anesthesia or OR setup. We have to arrange some precautions because if patient travel after implant, sometime alarms happen in the airport and stuff because the half-life is 60 days. So we advise them to carry the card, but not everyone would look into the card first before catching the person for carrying the nuclear bomb in themselves. So that's some unusual things happen and phone calls we receive. So these are the results from Cross Cancer Institute in Alberta, Canada, where we did 10 years and published our data. And the cure rate you can see as expected in the early stage prostate cancer is about close to 90%, and toxicity profile was very good as well. One of the issue in the Western country is that cremation right after implant is not possible. So those are a little bit challenges, but I don't think we have that issue. So we don't need to mention that. And I showed our own data, but there's a famous data from Grimm's in Seattle, USA. And there is no head-to-head comparison of brachy with external beam or surgery. Not possible. We open a study and patient will come and tell us that I decided this option or other option. You're not the one who will decide for me. So we have to close the study when we open it. So this will never happen. So he plotted the brachytherapy, external beam and surgery, not to show the surgeon are not doing as best. It's just an overlapping. This is non-significant and it's just head-to-head comparison. So brachytherapy at least equivalent to all other options. So I would not claim it's a better option. It's equivalent option to other. So this option I feel we should have available for our patient in our region. So alhamdulillah, after a long effort, we're going to have that option in Oman. It will be open to people in the region as well with very reasonable prices, which I'm negotiating at the moment. Now the salvage, this is very crucial. If someone failed after external beam radiation and surgery is not possible or other option not available, this is really a very good option. So I have my personal experience in that area. So therefore I want to present that I was part of RTOG 0526 study, have done quite a good number of patients on this study. The study was about 100 patients and we now updated the result as well. This is a little bit older slide. I should have upgraded my slides, but So 5 year, about 60% plus patients are still alive, disease-free, without hormone treatment. So this is a really good option. And I think this is the best option for those patients, and this should be available. So this was my main reason to fight for this option to be available. So we have that now. And with this conclusion, we will update the results as we move along. But now up to 7 year, 8 year data, and data is good. I have to admit that initial couple of my patients suffered more than the later on. So that was my learning curve. So we learned through, that the how to actually perform is a little bit different from the patient who didn't receive external beam radiation. So it's the full dose of both treatment option, which is not an easy one. This I included. HDR brachytherapy is another form of brachytherapy. I included, some people are interested in. It is not my topic of discussion, but that can become, but this is not monotherapy. That is one of the issue. However, it is easier to perform anywhere where the resources are limited. So because we have gynae brachytherapy and use the same source, so it costs us less. And it is used in combination with external beam in intermediate and high risk. And setup is very similar. You saw the other brachy is lithotomy and put the plastic tube in, connect that with the radiation source and treat them. So, and this is how the picture looked like for that prostate. So prostate, urethra, plastic tubes in, treat and remove them. So that's different from the other one. So I would now move to the moderate hypofractionation. So switching the gear, that was a very different option. And now talking about external beam radiation. So in the external beam radiation, we call it standard radiation, where we give 1.8 gray to 2 gray per fraction over 39 fractions over 8 weeks time for the patient to come every day for the treatment. And that is from the linear accelerator or any other machines which we use for external treatment. So this was when I was a fellow in Canada in about 2004. I suggested I study where we can utilize the those days new ideas of alpha beta ratio, where it shows that some tissues grow slow, some tissue grow fast, and the amount of radiation delivered in one day or and over a period of time can be different in different tumor. The time when I was doing all my residency, everybody was treated with same standard. But then we start learning that prostate cancer is different, or prostate tissue is different than breast, than stomach, or for lymphoma. So we have to do differently. So alpha beta ratio come to be very low for prostate. It means very slow growing tumor. For that, we found those patients, if they given larger dose of radiation every day over a shorter period of time and a smaller dose, total dose, will do better. So that was theory. So someone have to test the theory. So we took the lead and started suggesting, let's do the trial. And it was very hypothetical. There were other centers were also starting the similar concept around the globe. We come to know later on. So we thought at least there may be, my idea was that we may do better by doing hypofractionation. It didn't turn out to be that. It turned out to be, it is better in terms of shorter duration, but results are similar. So these are the moderate hypofractionation major trial, very famous in intermediate and high risk. It's a mixed bag. And I don't want to go into detail because the one which I want to talk is only in the high risk. So in the high risk group, these are the two main trials. So this is the one which I started. It took me a long time because first we did phase 1, phase 2, and it take time, but we established the concept. And then I started this CHIRP study there in Canada, and then they left Canada. My colleagues continued and completed the study, and they compared 39 fractions versus 25, and now recently published, and their outcomes were similar. Their toxicity was similar, quality of life was similar as well. At the same time, one of my friend, Tamim Niazi, he lived in Pakistan as well at some time point, and he's now in Montreal in Canada. He took the protocol from me and he ran a trial in there as well. And he completed it faster. And now in Astro this year, now a few days back, he published that data. And there they all agreed that this is an alternative option for 68 gray and 25 fraction. From our protocol then from Tata Memorial, also a study done called POP-RT, and they did the same dose, but 2 arm, one with lymph node treatment or without lymph node treatment in high risk prostate cancer. And they found the results are similar, so they continued our way of treatment. So now there is a good evidence, and I'm thinking about doing a meta-analysis of this group of patients to show that this is a one very good dose as an alternative option, standard option. So this make 3 weeks shorter treatment. So how we did it, because I just would share you quickly, maybe someone from radiation oncology who may be interested in that, how we did the study. So we draw the prostate gland, seminal vesicle, pelvic lymph node, and we combined and we did all the like prostate, if it's only prostate involved, or seminal vesicle involved, whichever has the gross disease. We took the gross disease as CTV68 and the non-involved pelvic lymph node or if seminal vesicle is not involved, as 45. So 45 gray and 68 gray, these were the doses we use, and we grow the margin around that. So very key important thing is that the margin, we did very narrow margin in those patients because we're giving larger dose of radiation. And we were able to do that by using daily cone beam CT for verification, or if someone used the fiducial marker. So I don't want to go into detail of this radiotherapy detail. And we created a single plan. So first advantage we get, instead of 2 plans, we created a single plan. We save our physicist time, and we have our restriction dose. We calculated those days by the biology, but now we have clinical data to compare with. And we did the verification for those patients on daily basis, because prostate is not, there's a little bit of video, but it's not moving. So that's why not very important. That, you know, the prostate gland move every day. So we don't want to miss because of the narrow margin. So we did daily cone beam CT. We did very strong rectal prep, because rectum filling can move the prostate out. So we make sure that everyday patients were treated. And by doing this, so either someone should use fiducial marker or daily cone beam CT. And we set up, this is what I suggested them, that we set up on the rectal prostate interface, because we don't want rectum to be higher dose and prostate to be lower dose, or vice versa. And that come out very well. And now this is recommended strategy. So those were our theories, which actually worked well. And these were our results. So results are very similar. Actually, what in the longer run, which I know about 85 to 90% outcome at 5 years time, which is really good for high risk prostate cancer. So I have only a few more slides left. So that was for the high risk prostate cancer. And now I'm switching here to the next level, which is very commonly used. And the studies I will show you, most of them are presented almost every site. Breast cancer, I was there, was presented. So what we were, as I mentioned, that in the stage 4 disease in the past, which I was feeling as a resident, I never believed, and I was working towards this as well, is that stage 4 disease doesn't mean that you just give up on the patient and give them hormone treatment. Now, there are lots of systemic treatment options came as well. So that's what our main treatment as a palliative radiotherapy we're giving for pain relief, but now it's changing. And now with the advancement in stereotactic body radiation, where we can deliver by using newer technology, higher doses of radiation, we're delivering that in a very short time interval, like within a week, within few sessions. And therefore, we start using this in the low burden metastatic disease, not the high burden. If someone has very extensive disease, then there's no point using that. This is a very busy slide, and I don't really want to convey any of these messages here, because you'll find this aureole, stomp, saber comet everywhere in every site. So because what they did, they combine all other sites as well, including breast or prostate. There are only few patients from the prostate cancer in here, and they all showed the same, that, you know, if we give stereotactic body radiation, it improved the survival in those patients. Extend may be the one which not more commonly known to the people, is that where they actually try to cut down the systemic treatment. Actually, the current standard is systemic treatment, dual treatment, like you do one hormone treatment or second hormone treatment. So this is now we did actually added SBRT, and we said SBRT have role which improve on top of these two. But some people trying to challenge, okay, maybe we use one hormone treatment and the SBRT, and maybe we are equal. Now we are in an ocean. We don't know where we are going and which direction, but we will know. We are going that direction, that we will know what combination is the best for the patient. But we have to build the evidence for that, which is the phase going on. So I just very quickly submitted one ESTRO abstract before I come here. My center is only 1 year old, and in 1 year, I saw 10 patients which were which were regionally advanced or metastatic or oligometastatic, to my surprise, because if you look into Oriole or other studies in Canada over 3, 4, 5 years, they collected very few patients. So in our region, this cancer is this stage of cancer is very common. And that's embarked me that we should do study and combining the regional collaborator as well. So I submitted an abstract of retrospective review of these patients. So I treated some of my patients would have up to 20 metastatic site. So oligometastatic definition is up to 5, but I treated up to 20. Their volume was low, some paraortic lymph node, some pelvic lymph node, bone metastasis, everything. And I treated SBRT treatment for those. And very short follow-up, I cannot claim anything, 5.5 months, but PSA is undetectable in every single patient. So this is short-term result is very good because at 0.01, it is not detected. So my medical oncology colleague claimed that this is all because of my systemic treatment. I said, thank you very much, but I have to show him 2 or 3 patients. He cannot give him the second line hormone treatment because of comorbidity, but they also have undetectable PSA. So now he started thinking, and before I come here, we submitted a study proposal. And I talked to my colleague also last evening, that number of metastases is not the good marker. We should look for another. And in my mind, I'm thinking volume of the metastasis. So we would work on that. So I submitted study, was immediately accepted by our group. We'll start some form of study in our center, and then we go around. We can work together for that. Pakistan is a very good venue. So to summarize, I'm going to summarize those same points, that LDR brachytherapy is an important alternative option, should be available for our patient. It is now available in Muscat. Anybody interested and want to, instead of going to US or Europe and pay for high price, we can do that for cheaper cost. They can contact me. And I'm negotiating with Oman for the patient who will come from the Pakistan for prices. And then moderate hypofractionation actually should be utilized now in our region. It saved the resource, it saved the patient finance as well, and it is good results or outcome. And the stereotactic is the one which we should explore more and more together, and we should be given that option. So these are my talk, and if my apology if I took the longer time a little bit, but these 3 messages I want to discuss. And in the end, with the permission, I will say that we created a society called MESTRO. Pakistan is in it as well. So people who don't know about it still, please go to this MESTRO.org website, register for free for our first conference on 2nd and 3rd of December. And that conference will be the beginning of this organization, which is radiotherapy organization for the region. And for that, we want to have more and more people. Studies is actually hybrid conference where you can attend virtual as well and free registration. So please, as many as can register, and then also look into the membership, because good Pakistan representation would also be good. So thank you very much for all this.
Thank you very much, Nadeem. And thank you for giving us a talk on a specialty which is still evolving in Pakistan. And not most or all, but few oncologists are still like treating or dealing as a medical oncologist and the radiation oncologist. So we do need more radiation oncologists in Pakistan. But anyways, thank you very much for talk. We will briefly take a few questions or comments if we have. We are behind schedule, but if there's any question, please.
My name is Dr. Inside, I'm a resident at Clinical Radiation College, Shaukat. My question is about SBRT. How would you sequence SBRT in the metastatic disease between chemotherapy or would you be treating if they are symptomatic or?
Sure. I have very good medical oncology colleagues here as well, and actually clinical oncology colleague who does the both. So they will confirm me that most commonly now we use hormonal therapy. So we use duo hormonal therapy. So we use LHRH agonist as usual, and then added ABE or ENZA. With that, there is no issues with interaction. So all this 10 patient data I submitted, only 1 patient of grade 2 toxicity, urinary short term, and none others. So that was with the duo hormone therapy in 7 patients out of them. So it is very well tolerated. So I don't interfere the systemic treatment at all. With that, we can give the respiratory treatment.
Thank you very much, Nadeem. We have to move on. And our next,
Thank you very much.
Yeah, thank you. Our next speaker is from UK, Dr. Zishan Aslam, and he is giving his talk. It is a virtual talk, so we'll see, we'll check with our IT people if we have Dr. Zishan Aslam online. And it is a recorded one, so if we can play his talk, please. His talk is on the management of small renal masses. And I was told by Dr. Usman that after this final talk, we do have a panel discussion. We have our panelists. So please save your questions if you have any, and it will be an interactive session. So, just bear with us for another while. Thank you very much.
Good morning, everyone. I'm Zishan Islam. I'm a consultant urological surgeon in Nine Mills Hospital and Medical School in Scotland. And I'm a graduate of Dow University of Health Sciences from 2001. And my area of expertise is in renal cancers. Thank you very much to the whole scientific committee of Shaukat Khanum Cancer Center for inviting me as a speaker for this wonderful cancer symposium. It is an absolute honor, and it's because I still remember the days when we used to do fundraising during a school in Pakistan for Shaukat Khanum, when this hospital was under construction, and it's really privileged to be here as a speaker now decades down the line. My apologies that I cannot really attend this live session because it's on call weekend for me, 5th of November. Another apology, as I made a little bit of error in the title, which is slightly different because I realized it's a 20-minute talk. So the main focus has always been on, which I'm going to speak about, is active surveillance for small renal masses, which is a very interesting subject for kidney masses and an area of never-ending research. So the contents are some introduction to RCC and small renal masses with active surveillance, some evidence, stratifying risk, the role of tumor growth, kinetics, renal biopsy and imaging, some international guidelines we are going to look at, and a few take-home messages on this subject. So RCC is a big global health problem, as the incidence has been rising, approximately 30,000 new cases only in UK, which is a population of about 67 million. The incidence varies worldwide, but there is a rising incidence in developing countries as well. And the rising detection is mostly because of incidental diagnosis with imaging done for other purposes. And that's how about 50% of renal cancers get diagnosed, not just a small, but the large one as well. The standard of care has been intervention, of course, with partial nephrectomy or ablation when the patient is fit. But active surveillance clearly is reserved more for unfit elderly patient. So small renal masses is a spectrum of disease, and it ranges from benign lesions, 20 to 30%, to 10 to 20%, which are actually aggressive RCC. Majority, they are intermediate risk and clinically indolent. The natural history, from some evidence we are going to discuss, is low risk of metastasis when the disease is stable. It's static, it's not significantly growing. So active surveillance is for incidental SRMs in patients with significant medical comorbidity. That's where it is mostly reserved for in most of the guidelines, and where the risk of treatment can be more than the cancer-specific mortality or morbidity. And this is the deciding factor when we counsel the patients. So the goal is to avoid intervention when risk of treatment outweighs the benefits, regular imaging and patient review, and clear threshold that when we are supposed to change active surveillance to intervention. And from this graph, you can clearly see that as tumor size increase and gets close to 5 centimeters, that's where risk of metastasis become a bit more substantial, as you would expect. So what exactly is the evidence? The risk of metastatic disease with SRM is low, less than 2%. But a lot of data is retrospective series or cancer registries. Prospective long-term follow-up, very few studies done for that. And another thing to mention is that in the majority of the studies, there were no renal biopsies performed, which means that 20 to 30% of these lesions, they were benign. But this is again an important point, that we give patient a chance that they may be in the benign category. And another thing is that benign lesions tend to grow as well. So more or less, we have to deal with them when it comes to surveillance in the same category. But the point is that obviously, the actual cancers would be 70 to 80% rather than 100%, which generates the data. But the general consensus remains that metastatic spread is rare if follow-up is adequate and patients, they proceed to treatment when they are advised to, which means that they do follow the protocol. So some of the data we are going to discuss, that active surveillance for selected patients with renal masses. It's a small series, 44 masses in 35 patients, and median follow-up was up to 4 years. So only 2 patients developed metastatic disease, that is about 5.7%, both at high growth rate. But we have to take into consideration when one got lost to follow-up and returned almost 40 months later. So would have been avoided if he had continued on the follow-up. And the one was advised to proceed to surgery due to high growth rate, but the patient continued to active surveillance, and obviously that could have been avoided as well if they had agreed to intervene at the right time. So the true rate of metastasis if patient was compliant was about 2.9%. So key findings: no metastasis in any patient with tumors less than 4 centimeters. And I have to say that 4 centimeters is the cutoff for defining small renal masses. In actual practice, a lot of people, they define it as 3 centimeters as well, but generally it's T1A, 4 centimeters, that is generally defined as small renal masses. This is the most important study by Michael Jade, and even 10 years or 11 years down the line, this is the most important to quote to the patients and counsel them. 209 masses in median follow-up about 2.5 years, and the patient not just in imaging but biopsies as well. And progression, they define at what point intervention should be considered when size crosses 4 centimeters, tumor volume doubles and doubles in less than 12 months, and patient develop metastatic disease. So 25% had local progression only, and 2 cases out of these 178 patients had metastatic spread, that is 1%. So that's 178 patients. So if you divide, if you just get the calculation from 290 small renal masses, the percentage is even lower than that. So again, similar conclusion, that very low risk of progression within the first 2 years, and small renal mass growth rate is low. Even if this is a very important point, that even if biopsy has shown this is RCC, there's still room for active surveillance for a certain duration, right? Eventually, patient may have to consider some treatment if they have a longer life expectancy. So initial period of observations appears safe. So another study, systematic review, meta-analysis, about 880 patients. 10 of them, that is again 1%, progressed to metastasis, and only 2 of these had tumor 4 centimeters. Otherwise, they were higher than that. So predictive factors was increasing age, and as one can imagine, larger initial tumor size and high growth rate. So again, similar conclusion, metastatic spreads tends to occur late and it is low, and delayed intervention can be considered when tumor shows growth rate. So this is another 5-year study, 500 patients and delayed intervention surveillance for SRMs registry. That's where the data was extracted. 223 SRMs on active surveillance, no metastasis at all at 2 years follow-up, and 274 was treated with primary intervention during the same period, and they developed 2 metastasis post-surgery. But clearly the masses size was slightly higher, slightly larger in the primary intervention group. So that is to prove that active surveillance is non-inferior to primary intervention up to 5 years follow-up in small renal masses, again giving that space for the patient to have a period of surveillance if they like. So stratifying a risk of progression, at what point we decide that patient should undergo intervention. Some of these studies, which are few, they are on VHL cases, and then no patients with SRM less than 3 centimeters suffered metastasis. So this data may not be directly applicable to sporadic incidental RCC because histology can vary, may behave differently from sporadic RCC, and approaches developed to guide clinicians are growth rate kinetics, and renal mass biopsy could have a role as well. So this study is by Smolder and Juke, which we have already touched on. The first study, approximately 25% of patients demonstrated no tumor growth, and none of these developed metastasis. And predictors of progression was defined as mean linear growth rate 0.8 centimeter per year, and versus 0.4 centimeter among those which does not progress. Mean volumetric growth rate 27 centimeter cube per year, and so these are the kinetics we have to consider. Jade's study in 2011 had suggested that no difference in growth rate between malignant and benign tumor. It was a two-year study, and that's again a very good counseling point for patients that they can have surveillance for a certain amount of time. So how is this data guiding us? So basically, at the zero growth rate, one can continue active surveillance with favorable outcomes, right? But if the linear growth rate, we have taken a cutoff greater than 0.4 centimeter, then there's a high risk of metastasis. There are some studies which I have not included. For example, a famous study from Oxford, David Cranston's study, where 0.5 centimeter was described as cutoff in their 2-year follow-up. Renal biopsy remains again a very controversial subject, which really leaves us in a little bit of a dilemma on a daily practice. But the idea is to differentiate between benign versus malignant. Routine biopsy remains controversial in these cases, and the proponents had suggested that it has a high diagnostic value, it is safe, and has a high concordance with the final pathology, whereas opponent says that you can still do active surveillance without histology. The morbidity and risk in patients with coagulopathy needs to be considered, and that's why they oppose. But one of the factors here is again that despite a negative biopsy, one cannot really guarantee that this is kidney cancer, and that's where in a youngish patient age group, biopsy, generally most physicians, urologists don't recommend biopsies. So if we combine these, yes, biopsy could differentiate between oncocytic tumors from aggressive ones. If you know this is a chromophobe, then again, that has a much less aggressive course. And again, you can consider active surveillance depending on patient circumstances. And then it allows informed decision-making about continuing or proceeding to surgery or ablation, whichever is suitable. So this is moving on further in the next 5 years, how active surveillance and generally small renal masses could be really helped with this new technology of systemic nuclear medicine scan. This is used for parathyroid glands, but has shown a lot of promise in differentiating oncocytomas and less aggressive tumors from conventional ciliary cell RCC papillary, which has more magnetic potential. So basically, obviously, without going too much into the physics and everything of nuclear medicines, this is a mitochondrial concentrating agent and has a high uptake in tumors which are packed with mitochondria. So, for example, oncocytoma, chromophobe tumors, and hereditary oncocytic chromophobe tumors, they would have a more uptake, as you can see on this in this part of the slide, and that just guides us whether these are oncocytomas or HOCT, and both of these can be put on surveillance, even despite that hereditary oncocytic is a tumor, but it's very minimally, it's very yes, minimally aggressive with negligible risk of metastasis over a certain time period, and that can be combined with biopsy and gives us more reassurance. This study was from Johns Hopkins, which has suggested promising results, but it's still I'm not sure whether it's being continued there or not. Another study on the similar subject was, which has again suggested similar results, high sensitivity and specificity for characterizing benign and low-grade renal lesions. And again, it gives a lot of diagnostic confidence with indeterminate renal masses. I myself has done some of these scans, about 8-9 patients, and 2 of them decided to go ahead with partial nephrectomy despite this scan and biopsy because of anxieties, and they came back as oncocytomas. And the results of the scans that we have done are very promising. I mean, it's a very small series so far, but it shows promise, and hopefully in 5 years' time, this would have a big role. So patients on active surveillance, quality of life has to be kept in mind as well because of the anxieties. And we would know this has been an issue with prostate cancers on watchful waiting, and a lot has been done regarding that. Diagnostic uncertainty could be associated with poorer overall quality of life, poor cancer-related quality of lives, and anxiety levels, and negative impact on psychosocial well-being. And in my humble experience of 7-8 years, these factors again affect more if you are thinking about youngish patients. But again, with good counseling with elderly patients, giving them some statistics, these can be all overcome. So it may be just linked to unnecessary intervention patients desiring for. So that's why counseling and reassuring is so important. So don't really choose unnecessarily to go down treatment route. So RCC specific mortality has to be considered again where counseling these patients. So for example, patient with SRM has approximately 1 risk of metastasis, 1% risk, as we have discussed. And we are talking about patients who are mostly in their 70s and 80s. But if we look at these statistics, that competing causes mortality rates, they could be much higher than cancer-specific mortality rates in small renal masses. And this was over 65 years. So when we are going into 70s and 80s, that these competing causes can become even higher. And that's exactly where counseling comes in. And sometimes we have to be really like open with the patients and blunt that an 85-year-old, that yes, in 5 years' time, this cancer, this renal mass will progress, but it's unlikely to progress to a level where it will develop metastasis and results in patients' mortality, patients' life expectancy, whereas others could. And that's what patients sometimes, or most of the times, are very happy to hear and make the decisions. In fact, we sometimes come to a patient who have 2-centimeter lesion and who are in their late 80s, and they just decide not to have any follow-up at all when they discuss these statistics. This is another CR analysis, 1983 to 2002, about again thousands of patients, 26,000, where tumors less than 4 centimeter, 5-year cancer-specific mortality was 5%, whereas oral mortality was 28%. So we have to assess the competing risks to mortality, having an open discussion with the patient. So some of the guidelines like AUA, it is level 3 evidence, weak strength, but what it suggests is active surveillance cohorts. The growth of small renal masses is low in most cases, and progression to metastatic disease is rare. and offer active surveillance or ablation in comorbid patients. AUA has their own charts regarding these patients counseling. They recommend imaging, as we would do. I do 6 months, 12 months, 2 years, 3 years, 4 years. This is what we have decided with our radiologists. And at that point, we have a rediscussion regarding discharging the patient should the lesion remain stable. And that's where youngest patient, we don't do active surveillance, because if a 50-year-old have a stable 2.5 centimeter lesion, even for 4 years, he will be 54. And even at that point, I won't be comfortable discharging him. So that's why right away, we just go ahead with biopsying or directly going for partial nephrectomies for these patients. So AUA's cutoff is tumor size greater than 3 centimeter, which I think is very reasonable. Stage progression, and they also take into consideration kinetics as well. So to summarize, active surveillance, when do we go for intervention? When tumor size greater than 4 centimeter, growth greater than 0.5 centimeter, patient symptoms and preference intervention. Again, I would emphasize, we are talking about elderly growth. In a youngish patient, even if we go for intervention surveillance, my cutoff would be a bit lower, maybe like 3 centimeter. So a few take-home messages. The overall risk of metastatic spread with SRM is low. Initial observation is usually safe in significant comorbidity, and this initial observation can be long-term as well, depending on patient's life expectancies. Not recommended for patient fit for treatment. In my practice, when I talk about fit youngish patient in 50s, 60s, it's really important, all this data and stats, when patient have some other illness going on, for example, some advanced cancer, other cancer, which has actually imaging has diagnosed a small renal mass, or patients who had a recent, let's say, myocardial infarction, and they are on dual antiplatelets for 6 months. So, and they cannot come off that. So at that point, it really helps with counseling them that, yes, risk of progression is there. We rarely have a 0% figure in our practice, but it's extremely minimal the risk, so they can really focus on other areas and come back in 6 months' time. And decision to observe, yes, patient is specific, and we have to just see risk benefit analysis, and tumor growth kinetics, biopsy, they have their role, and so is the imaging, as I have discussed. So look, availability of imaging, ease of follow-up, that also has to be considered, and that's where we often have these discussions that, for example, in Pakistan, yes, at times we have patients coming from far distance away from villages, but even in urban areas, patients may not be so compliant with the follow-up. So we have to look at these social circumstances as well, about putting patient active surveillance, whether the patient would have a tendency to just disappear, or it's best to just go ahead and just treat them. So this has to be kept into consideration as well. So thank you very much, and I may not be available for direct questions during the session, but this is my email, and I would really welcome any questions, any comments, anybody who wish to contact me regarding this. Thank you very much.
We would say thank you very much to Dr. Zishan Aslam. In his absence, I'll convey him my thanks personally. And I think with the permission of Dr. Usman and the Khuramir, we will move on towards the panel discussion. If I may have your permission, I would like to request Professor Said Hussain to please come on this chair as a panelist. And the next gentleman I have is Dr. Faisal Azam, please. Please, as a urologist, yes, please take your mic. So, Dr. Hussain, please. And I would like to request Dr. Nadeem Parvez, the radiation oncologist, please take the chair. Now, so with your permission, yeah. So basically, it is going to be an interactive session.
session. So please feel free to ask any questions you have about the talks you've just heard. And we would like to keep the order of the talks. So we will start with the metastatic renal cell carcinoma. So if you have any questions on that topic, please feel free to ask any questions from our panelists, and then we'll move on. Yeah, please go ahead.
My name is Dr. Jas. I would like to ask, when will you prefer this kind of patient for surgery and then because the controversy in stage 4 should we do systemic therapy and leave the surgery, or should we send the surgery metastatic?
Thank you very much. It's a nice question. Yeah, this is a very nice question actually, and this is a controversial topic. When will you do surgery, or will you do a surgery or not? And there are a lot of trials which showed in the era of all the systemic therapy, there's no need for you probably talk about nephrectomy. Yeah? So cytoreductive nephrectomy might not be the preferred option, but things are changing. There are no new trials coming, and there are currently few trials going on where they are recommending actually to have a cytoreductive nephrectomy. But I would start with the combination therapy and then assess the patient, especially in the low volume disease. And I have many patients actually who have, after 3 months of treatment, they have responded very well. Especially in metastatic disease, I currently have 4 patients who had complete response in metastases, but they still have the primary. So I've sent those patients for nephrectomy. So still it has a role, and we are doing it. Although if you look at the randomized trial, currently we do not have any strong evidence for it, but there are currently trying going on. But I would go for those patients who respond well for a nephrectomy.
Any other question? Please come forward.
But my question is that how would you treat a patient who has margin positivity after the surgery in the clear cell renal cell carcinoma and non-clear cell? As a patient has a PTC, but it's a margin positive.
Right. Okay. Right. So you're probably talking about the non-metastatic. Am I right? Yeah. So margin positive as such, for clear cell or non-clear cell carcinoma, the evidence for systemic therapy is mostly in metastatic setting. So is margin positive disease, would you consider this as metastatic is the question. I do not consider actually that to be metastatic. So would you give radiotherapy to those patients? That's another topic. We have a radiation oncologist here, though he can comment on it. But regarding systemic therapy, it depends on what do you believe, would you give it or not? I personally do not give it unless we have an evidence, because otherwise there's no target for you to see the response. And the recommendation is for those patients who have visible disease on the imaging to have a systemic therapy. But what do you think, Nadeem, about radiotherapy?
That's a very good point. And the most of the time with the margin positive, if it is microscopic margin positive, we don't even know where the margin is, and usually there's no clips. So what to radiate, and there are very many sensitive structures around. So we don't usually treat. But if there is a gross residual disease where you can mark, there is the question come whether you want systemic treatment or radiation. So that's very case-to-case basis on MDP decision basis, that where some cases we agree to give SBRT radiation treatment, then followed by the systemic treatment. But there are no clear evidence in this area. However, be case-to-case basis.
Yes, Dr. Hussain, please.
Yeah, Faisal, I would just like to add on here, means again, these are high-risk cases, whether there is a role of adjuvant treatment here based on the, based on the data. I think these are high-risk cases where, again, if you look at the access is a different scenario, whether we have access to the drugs or not, but adjuvant pembrolizumab will be indicated in these sort of settings.
Yeah, so there are trials for adjuvant also. We have positive trial with sunitinib, and now positive trial with pembrolizumab. those can be considered. Again, there's no strong evidence for even adjuvant treatment, and I personally have not used adjuvant treatment, although pembrolizumab data seems to be more convincing than the VEGF TKI previously.
Yeah, I mean, that's what I was pointing to. I mean, I think based on the available evidence, Manan, your question, again, looking through the evidence, that will be something. Again, access is another issue which we all have to work together on about availability of the drugs. But based on that data, it is available internationally and patients can get access to that.
By the way, I just have a comment to add to that. When talking about margin for the pivotal, two kinds of margins. One is vascular margin and the other one is the vascular margin. Sorry, peripheral margin. Now, where do we get the body? The whole ethos about so what I believe is that we need more robust, more aggressive follow-up, so that if there is metastasis, then and then of course, so this is the way we have been dealing with it.
So that seems quite reasonable.
Any other question, please? Yeah, go ahead.
My name is Dr. Murthy. I'm from Uro-Oncology in Shaukat. My question is that in a patient where we have a large tumor burden in the kidney, and also we have a large volume microscopic disease. So in that case, would you like to take the kidney out in the first setting, like a cytoreductive infection, go for the upfront systemic treatment? We have a case particularly that we saw in our MDD, so there was discussion. So we know that with the certain trial in the high volume activity, there is the role of the upfront systemic therapy compared to cytoreductive therapy. What you would take?
Thank you. Next question. It depends where the patient goes. If it goes to urologist, they will take it out. Just a joke. No, actually, the systemic therapy is recommended for these patients unless there's some sort of emergency. If patient is symptomatic, so and it could be any other, the mass is so big, it's causing compression symptoms, or if it's painful, then it's worth going for surgery first to improve symptoms. That's not, you're not treating the cancer overall, but you're just improving the symptoms for us to give treatment. But I prefer to give systemic therapy. And as I mentioned, combination of VEGF TKI with immune checkpoint inhibitors is my preferred treatment. And if I have personally went for pembrolizumab plus lenvatinib with a very quick response. A response in just 2 to 3 weeks, symptomatic improvement, tumor shrinkage, all those. So you can go for that. But if you believe it's some sort of emergency because of the mass, surgery can be done, which should be a palliative surgery.
Any other question?
So what has been your experience with the use of immunotherapy, and in which side effects you will not reach any immunotherapy?
Thank you. So immunotherapy in renal cell carcinoma is usually quite safe, to be honest. In melanoma, I do melanoma also. I see a lot of side effects because of the high dose of anti-CTLA-4 antibodies. But here we are using most of the PD-1 antibodies. So usually not many side effects, but of course we do come across. So the one I'm really scared of is the pneumonitis. Even grade 1 pneumonitis, I try not to re-challenge them. Okay, but apart from that, I have re-challenged patient in almost all the other side effects. Even grade 3, if they go back to grade 1, I will try to re-challenge them. And in most of the renal cell carcinoma, honestly, the side effects are not immune related. Side effects are more of the VEGF TKI. So what I do is I stop the VEGF TKI, continue with the immunotherapy, and then slowly introduce the VEGF TKI later on. So I've done that quite a lot with pembrolizumab and axitinib combination, where so sometimes the side effects are similar, like hepatotoxicity happen in both. Okay, so which one is the culprit here? So initially, if it is grade 3, just stop it, both of them. When it becomes grade 1, start the immune checkpoint inhibitors, monitor the patient. If they are well, then introduce the axitinib, lenvatinib, or cabozantinib at half the dose, and just slow keeps building up on the dose. Most of the patient, they are fine.
Any question?
Can I answer?
Yeah, sure. Please go ahead.
So just a quick question that in this whole discussion, if this renal cell carcinoma oligometastatic, do you try to approach the radical treatment or using SBRT radiation treatment for those patients?
So your talk, yeah, I do actually. We have SBRT, and our colleague in our center is very active actually. So we Fahad, and there's another one, Shaukat. So we have a tumor board, and they sit in it. So they usually pick. They say, I can treat this. So, but anyhow, I start with systemic therapy, and then we usually 3 months, 4 months, and then we do ask for SBRT. Yes.
Yeah, just for a comment that because of SBRT treatment is so short that we don't delay systemic treatment. The main aim is systemic treatment, and we give the higher radiation. Before I come here, I treated a patient. Even for palliative purpose, I use SBRT because renal cell carcinoma was relatively radio resistant. But by SBRT, we can give higher doses of radiation. So even palliative control is longer duration.
Yes. So we are using it.
Please go, Dr. Hussain.
Great. Just wanted to make a comment about the last question about patients who are borderline operable for nephrectomy. In UK, we are setting up a trial. I did talk about window of opportunity trials. And again, with the urologist in the audience, I take that opportunity that actually, because the number of cases, speaking to the medical oncology colleagues here, talking to Adnan Jabbar from Karachi, Zeba Aziz, and all, you have got huge number of cases. And again, these are the opportunities. There are challenges, but huge opportunities in Pakistan. And that's one example which one of the fellows asked that question about, where there's a borderline case or inoperable. That is exactly the patient population where we are setting things up for kidney cancers as well, where we give systemic treatment, as Faisal said, giving IO plus IO or IO plus TKI, then taking the kidney out, and then basically looking at that and learning from it in terms of resistance pathways and response, patients who will respond very well to these treatments radiologically, and you've taken the kidney out and then learn from that tumor biology as well. So those are the huge opportunities that we really should try and embrace and get most, because those are sort of studies you can do in 12 months, big number of cases to get some meaningful data out.
Yeah. I have a question for Dr. Usman. It's sort of a generalized question, sir. And I would like to ask you, with all your experience, where do you see the uro-oncological care at the moment in terms of collaborative, the work between the medical oncologist, the radiation oncologist, the urologist, and the palliative medicine? So, and the MDTs, in the hospital, and the regional MDTs and the network MDTs. So where do you see ourselves at the moment?
Well, in Shaukat Khanum Hospital, we have a regular MDT every Friday afternoon.
Yeah.
And the radiologist, the oncologist, the surgeons, and the pathologist, everybody's there. So if we have a patient who needs to be referred to the oncologist, he just takes over, or the radiologist. As far as regional things go, I think Sheikh Zayed Hospital has been doing a regular oncology MDT with a few doctors, Shamim Khan and Mateen, on a regular basis, once or twice a month. I think we can set up an MDT between the different hospitals, and we can do it online.
Yeah.
And, there is now good experience that, everybody can be online, and we can see each other on the television and then discuss our different cases. I think that's a good option.
Yeah.
I think we should all work on it and, start such a regular meeting. So we can share data, and we can get each other's opinions. I mean, somebody sitting in PKLI or Jinnah Hospital can get an opinion from an oncologist in Shaukat Khanum or a radiotherapist in Europe. And I think that would be a very good option and a very good.
Yeah, thank you very much. And Dr. Hussain, where do you see, as an overseas observer, how and where do you see us? Like, are we, progressing, because you've been the part of the MDTs online inside Pakistan. So how do you see things?
I think I see a very big positive changes which I've seen over the last 4 or 5 years. And I think Society of Medical Oncology Pakistan has contributed a lot of centers, people getting closer to each other. What Usman has just said is a really important point that, with PKLI, I'm there, Shamim Khan is there, Asim is there are quite a few colleagues from UK and other parts. Similarly, we've got some other hospitals with PKLI as well, which Nadeem is there, but there is Sheikh Zayed or some other centers who join us as well during those meetings. And I think those are really positive moves because, as I said, the numbers are huge here. And I think what we are lacking from Pakistan, one thing which I'm really a big proponent of, is to try and get data out from Pakistan. Because when I speak to global industries, when we are setting up in trials in UK and other parts of the world, and Nadeem has spoken to me many times about it, when I talk about Pakistan, I talk with passion that these are the cases. Yeah. These are the cases we discuss every 2 weeks when we have a meeting. There are 4 or 5 cystectomies, there are about 10 nephrectomies and all these, with a very good pathology report, which tells us all about what's going on. Radiologists on board. I think what we need to do is to get more data out from Pakistan, because it's one thing me saying about it. And it's another thing when you've got these reports actually published as in big meetings, but more importantly, as peer-reviewed publications. So that's where it's great to see a lot of fellows here who are here, who hopefully will see more of them. I'm meeting quite a few of Zeba Aziz's fellows today as well later on, and hopefully with PKLI team as well. So I'm seeing a big positive moves. And I think it's, people like you together here, having urologists in the room is again, a very big positive move. Yeah. Previously, when we talk about systemic treatments, we do see these treatments complement each other. So what means I'm a big proponent of organ preservation. I've worked on BC 2001, which was my work as a phase 1 trial 20 years ago. But I work in Sheffield, which is a big center for cystectomy, and we do a lot of window of opportunity trials. But the key thing is that for a patient, the best treatment lies somewhere in between. And the patient has to be given those information discussions to help them make informed choices. And I think I am really delighted with what I'm seeing in Pakistan. The changes, the database, which I've talked to Nadeem about, the database that is there in PKLI, the database I've talked to Adnan Jabbar when he was at Akhan, now he's at Ziauddin. But with Zeba Aziz, so you have got the database. It's really getting the fellows, getting them excited and enthusiastic about it, that these things will make a big change in the coming decades. That this is this is something we should all work towards and strive towards.
Do you have any question? Go ahead, please.
My name is Dr. I'm from the Khanum University Hospital. I'm a senior investigator in medical oncology. I have a question because we had an MDJ discussion in the urology board. And then we have this 22-year-old patient with an XP11 transplantation RCC, and the surgeon had did the surgery. Now we were wondering what kind of adjuvant treatment would do for this patient because we don't have any data, right? I mean, I was reading a phase reports and there was data on sunitinib in the metastatic setting, but nothing on the adjuvant setting. What would we do in that?
Right. Thank you very much for the question. So for this rare deletions, actually, we have few patients also in our center. As such, we do not have any evidence for these patients. So would you give adjuvant treatment or not? This all depends on the risk categorization of these patients. So you can give, I mean, the best evidence so far for regardless of deletion is for the immune checkpoint inhibitors, pembrolizumab. Rather than sunitinib, but specifically if you're talking about these deletions, yes, there's some evidence for using sunitinib. But then, how many patients do we have? This is the question. Okay, I have looked into it in my center. We only found over the last 10 years 3 patients. So whoever is doing study, I don't think so. There'll be much, and we need more calibration, as Sayed is saying. So if we found the data and see how people are treating it, we are currently treating it like any other renal cell carcinomas. So would you give adjuvant or not adjuvant? It all depends on what you think the risk of relapses.
Yeah. Okay.
Yeah, so this is how it would be good if we can collaborate. Yes.
So, and they're just on a regular follow-up.
My question is to Dr. Sen. So, in those patients who have non-muscle invasive bladder tumor, high-grade non-muscle invasive bladder tumor, and they are, they have a treatment failure like BCD, and they are not otherwise fit or not willing for this technique. So, do you have some sort of treatment, systemic treatment options? Are the interest that options for these sort of patients?
Yeah, I mean, sometimes they do basically retreatment with BCG. The key thing is that what is causing them to be unfit for. So the trial I mentioned to you, the INVEST trial, is again for those sort of patients who are, those will be fit for cystectomy. Your patient who is unfit for cystectomy, that is the reason they're not having it. Treatment options will be limited, endoscopic surveillance, because this patient is not fit for any, looks like, because of comorbidities. So endoscopic surveillance will be perhaps a major stay of treatment, but repeat with BCG, high-VEC treatment, mitomycin C, sometimes using gemcitabine and other stuffs as well. So there could be quite few of those heated sort of mitomycin C and all those sort of treatments are there. These are options as well in terms of these non-muscle invasive bladder cancers who are otherwise unfit for cystectomy.
And just, I think there's some evidence for pembrolizumab also, which can be used for non-muscle invasive in those patients who cannot have cystectomy.
Yeah, means I think
Not commonly used, but
yeah, you're right. Means again, there's a trial called POTOMAC trial, which is not yet reported, but that trial looked at BCG versus BCG plus pembrolizumab. So there is a trial that should be reported. We were one of the top recruiters globally, and that trial has completed recruitment about 18 months ago. So you should be getting that as well.
Thank you very much. You have a question? Go ahead, please.
I'm Dr. Yasser from Khanum. I have a question to Dr. Hussain and Dr. Nadeem. What about your opinion regarding oligometastatic bladder cancer with a solitary matter in the spine regarding radiation treatment? Have you experienced any patients in your practice?
I think that's a great question. Means again, that's the good thing about this meeting, because we talk about cases which we may have seen four or five cases in a year. But when you come to a meeting like that, you hear from colleagues and everybody talks about 4 or 5 cases, 10 cases. And I think that's where we need to work together. So I think there's no trial data in there, but you have learned in prostate cancer, you've learned from other cancers. Oligometastatic disease, the first thing is, I gave a talk last year at this Society of Medical Oncology. First thing is to reach a definition. What is oligometastatic disease? Is it 5, less than 5? How you deal with it. I think we have matured enough and we are coming to a definition where we all agree to it. Next thing is that moving it from prostate cancer to kidney cancer to bladder cancer and other tumor sites. So in bladder cancer, there's no study, but this is exactly something we've talked about, having maybe the definition may be different compared to prostate cancer. In bladder, you may be looking at 2 or 3 sites as oligometastatic and then doing a study with that. So there's no data, but yes, I do try. So example, even in nodal metastatic disease, when there are nodal mets which are outside of the field, quite often we do give chemotherapy and then reassess them to see how the tumor is and then take it from there. Would like to hear from Nadeem as well, what he feels.
And on MDT basis, again, those cases we discussed, and those patients who do either better on the systemic treatment, or we think these are oligometastasis, so we do give SBRT treatment. It's a shorter duration, higher doses, and we don't lose anything, by the way, because even if we don't cure those patients, we at least delay their progression. So there is it's a safe delivery for SBRT with the curative intent doses, but the treatment may not be curative. Treatment may be palliative, but better progression-free survival. So basically, these cases, the evidence is less in the bladder cancer than prostate or breast cancer, but we do select cases case by case, as Dr. Faisal also mentioned in the MDT. And then we do decide together that this patient should be offered SBRT.
I think if I may just add one more thing on that, is that when you look at that, for example, there's nodal mets and 2 or 3 bony mets. You see 1 bone mets which is responding to treatment and 2 or 3 nodal mets. So you can still call it oligometastatic disease because some of those sites are actually not changing at all. So how you make that definition, whether they're 5 sites or 6 sites, sometimes is depending on your response as well. So if 2 or 3 sites are responding and 1 or 2 sites, they may be benign. These are patients in their 70s and 60s. There may be other etiologies going on. So we have to give a, quite like what Nadeem said, that you're not losing anything. If you improve on their PFS and OS, that's something. Yes, we should try and do it in clinical trial setting. And this sort of a meeting is a great springboard for us to think about how we can design studies which we can all contribute to and work together towards.
You totally agree with Prof. Actually, that we should, there is a dire need to now have the studies in this area, and this will all change in the next few years. We will be practicing different. We're now talking about it. We should take lead because in our region, in Middle East or in this region, we see more cases, and Prof will agree that there is a need of number of cases. which we have, and not so many in the West. So I think studies are needed to prove that what we're doing is right or not, or what is the best approach for which selected patient.
Okay, I have a very common and a very key question to all the panelists. The key question in the mind of a patient diagnosed with an incurable cancer is, how much time do I have? So in your practice, do you use any sort of the nomograms or what to tell patient, well, look, you have 3 months, you have 2 years, you have 9 months?
I think that's a great question. This is something we all deal with on a day-to-day setting. I often like to talk to patients when I talk about first-line treatment or second-line metastatic disease settings. If they are palliative, I'm quite usually, we'll talk about the median survival is that. I always explain it to them. Median is in the midline. You may be in the other side of the half. You may be on the other side of, so we can't predict anything. But at the same time, that helps patients to have a little bit of a understanding that this is not curative, this is palliative, and there is a timeline to it. Delighted to say many patients with second-line metastatic urothelial cancer, we have 3 years and 4 years down the line, whom I treated 2-3 years ago. But I think it's important, in my view, to talk to patients. And it will be great to hear about you guys, because in Pakistan, whether the patients say, don't talk to me about survival, because, sometimes I do, when patients contact me or some of my colleagues contact me from Pakistan and we talk about patients, there are patients who will say they don't want to know, or sometimes patients' family, even in UK, I've got families who will say, tell us everything about it, but don't tell him because he will not be able to take it, which I feel, right, this has not changed then.
Yeah, please.
Right, so my experience is in 3 different countries, so UK, Saudi Arabia, and Pakistan. So, and different culture. So in UK, as you said, so we speak to the patient, we give them all these figures. In Pakistan and Middle East, we don't speak to the patient that much, and they don't want to hear actually most of the time.
Yeah.
It's the family where we talk to them. And I think it's much easier to speak to a family. We just tell them whatever it is. But I usually do not give them figures when they ask the survival. I just tell them about the median survival, but that at the same time, I tell them that does not mean that this patient or your father or mother is going to live for this long. So it varies from years to months, and it's completely different, vary to patient. So I usually do not leave it like this.
Yeah. Do we have another session here? Okay, I think that so we have to close this session, and thank you very much, everyone, for your participation. Thank you very much for panelists. Thank you.
Thank you very much.
All right.
Thank you very much. And then bags are expensive.
जी 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 हाँ बस ठीक 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 हाँ
Assalamu alaikum and good morning, everyone. So I'm Dr. Muhammad Usman Rashid, Senior Research Scientist and Head of Basic Sciences. With me, Dr. Sajid Mushtaq, the histopathologist from Department of Pathology, Shaukat Khanum Memorial Cancer Hospital, is going to chair the session. So we'll start our first talk. The first talk is about the screening and pharmacological characterization of macrophage binding aptamers. So Mr. Usman Akhtar from University of Bonn. So if the next one is from Umar Said, is he here? Okay, Umar Said, he's going to talk about parvolin 14 and parvolin 17 bind to HBX and CCC DNA, augment HBV replication and proteome hepatocellular carcinoma. So there would be 7 minutes for the talk and 3 minutes for the question and answer. Thank you. Mr. Umar Said, please.
Assalamu alaikum, everyone. My name is Professor Dr. Omar Said. So I am Chief Research and Development Officer at the IDC. And today, the topic of presentation which I am going here is the human parvalin 14 and 17 binds to the HBX protein and the CCC DNA, and it augments the HBV replication and promotes the hepatocellular carcinoma. So as you all knows that the HBV infection is about 5% of the whole world population, and it contains the HBV virion DNA, polymerase, core protein, S protein, and HBX protein in it. This HBX protein is basically the transcriptional transactivators, and it does not directly bind to the CCC DNA. However, it has the ability to enhance the HBV replication to several folds. So here in this research, we evaluated the effect of human parvalins 14 and 17 proteins in the HBV replication. So this is the generalized HBV life cycle. You know that the virus comes into the cell through the anti-CPS receptors. Hereafter, it enters into the nucleus, and afterwards it releases the relaxed circular DNA, which attains the formation of the covalently closed circular DNA. This acts as a template, and it produces the physiognomic RNA, which is translated into viral proteins, and it ultimately causes the assembly of the core particle. And here within the core particle, the HBV replication occurs. So this CCC DNA basically enhances the viral replication to several fold. Here we investigated that these proteins can bind directly to the CCC DNA. These can also directly bind to the HBV core protein, core particle, and ultimately it increases the viral yield. And afterwards, it's secreted out of the cells in high volume. The HBV CCC DNA attains the closed conformation through the binding of several proteins. However, in the presence of the HBX protein, it attains the open conformation and the viral replication is enhanced to several folds. This HBX protein is basically the promiscuous transcriptional transactivator, and it enhances the virus replication to several folds. Now, what are the PPIases? Basically, these are the peptidyl proteolysis transisomerases. They cause the twisting and folding of the function of the proteins, right? So this twisting occurs at the amino acids followed by the proline peptide bond. And among these, there are cyclophilins, FK506 binding proteins, and the parvalins. In human genome, there are two parvalin genes, the PIN1 and PIN4. So the PIN4 gene encodes the parvalin 14 and parvalin 17 proteins. Both of these proteins have the basic domain in common and the PPIS domain in common. However, the par17 contains additional 25 amino acids in the N-terminal, which enhances its replication to several fold. We have found that these proteins binding can occur at the RP, KP, or HP sites in its substrate. It has been shown previously that in the liver, the expression of the PIN4 gene is very high. Also, the protein atlas data indicated that in the HepG2 cell lines, the PIN4 mRNA expression levels were relatively high. So we speculated that this PIN4 might affect the HBV replication. Therefore, we inhibited the the HBV replication through use of the parvalin inhibitors. So the lane 2 and 3 are the controls. The lane 3 is basically solvent treated and lane 4 is the drug treated. So as you can see that in the solvent treated lane, the HBV core protein, core particle, and HBV DNA replication is shown. However, when the PIN4 was inhibited through the jugulon, as compared to the control, the HBV core protein, core particle, and DNA levels were significantly reduced. Similar results were obtained to the HepG2 cells and also in other cell lines and also with another drug. So here we investigated the jugulon, in which the replication was down. And when we treated with the PIB, again, the HBV replication was significantly down-regulated compared to the control. After the inhibition, we moved towards the PIN4 knockdown. We made several PIN4 knockdown mutants. And as you can see that once we made the PIN4 knockdown, so the relative protein expression is less. Consequently, the core protein, core particle, and HBV DNA replications were significantly down-regulated. Same results were obtained in another cell line, HepG2. Then to further confirm our hypothesis, we overexpressed the parvalin 14 and 17 proteins in several cells, including the HepG2 to 15. So you can see when we exogenously provided with the PIN4, this is the expression of the 3x flag tag par 14 and 17. So you can see that compared to the control, the HBV core protein, core particle, and DNA replication were significantly enhanced. So this clearly indicates that these protein increases the HBV replication. Then we performed the day-wise study and we found that with the passage of time at the day 3rd, the HBV replication was significantly enhanced as compared to the control when the par 14 and 17 were overexpressed. So you can see that compared to control, the core protein, core particle, and DNA replications were upregulated. Then we examined the similar effects in the infection settings using the anti-CP receptors. So herein we did the infection and knocked down the PIN4. So when the PIN4 was knocked down, the core protein, core particle, HBV CCC DNA levels, HBV transcription levels, and the core particle and DNA replication were significantly downregulated. Then same results were obtained to other cells as well. Then we performed the extracellular and intracellular division of the cell. So herein we investigated after the lysis that in the extracellular, when the par 14 and 17 were overexpressed, then the HBS surface protein levels were also significantly upregulated. And besides these, the HBV virion levels were also significantly upregulated. Herein, through the native agarose gel, we examined that these proteins directly bind to the HBS surface protein, which clearly indicates that these proteins might have further effects on the HBV replication. And ultimately, this also shows the direct binding of the PAR14 and 17 with the virions. So this is, sorry?
1 minute is left.
No problem. So same results were obtained through the intracellular. So herein we investigated that when the PAR14 and 17 were upregulated, all of the HBV promoters were upregulated. Same results were obtained through other cells. This is again, we have shown before that the transcriptional activation was upregulated in the presence of PAR14 and 17. Same results are obtained through other cells. Then we examined the cccDNA levels, and you can see that compared to control, the cccDNA levels were highly enhanced in the presence of these proteins. And once these proteins were knocked down, the level of cccDNA was reduced. Then, since PAR14 and 17 occurs in the in the same positions as the HBx resides, so in the cytoplasm, it occurs in the cytoplasm, nucleus, and mitochondria. So we speculated that HBx and PAR14 and 17 might have the close attachment. Then, in order to examine that, we use the HBx deficient system. So as shown previously, that in presence of HBx, the core protein, core particle, and DNA replication were enhanced. However, interestingly, when the HBx protein was not there, you can see there is no change. So this indicates that this replication is in the presence of HBx and dependent upon HBx. So once this HBx was provided in trans, you can see that the HBx, the replication was significantly enhanced. So overall, our study indicates that the PAR14 and 17 can bind to the cccDNA in the presence of HBx protein, and it enhanced the viral replication to several fold. We also examined the co-IP of these proteins, and we also determined the HBx stability. And we showed that these interactions occur in all of the cytoplasm, nucleus, and mitochondria. And we also examined that the PAR14 and 17 can directly bind to the cccDNA through the chip analysis.
Please just present your conclusion.
So in conclusion, these PAR14 and 17 are involved in HBV replication, and their activity is dependent upon HBx. And these are the novel binding partner of HBx, and they can enhance the stability of HBx, and they can directly bind to the cccDNA and upregulates the HBV from transcription in the HBx dependent manner, and ultimately enhance the cccDNA. So this is, I would like to acknowledge the International Center of Medical Sciences Research. Herein we to perform these experiments, and these experiments were mostly performed in the Aja University School of Medicine, South Korea. Thank you very much.
Thank you very much, Dr. Umar. Is there any question? If there is no question, we'll move on to the next talk by Mr. Noor Muhammad about the prevalence of FANCM germline variants in BRCA1/2 negative breast and ovarian cancer patients from Pakistan. So I would request that there are 7 minutes for the presentation and 3 minutes followed by for the question and answer session. Please stick to the times. Thank you.
So, Bismillahirrahmanirrahim. I am going to talk about the prevalence of FANCM germline variants in BRCA1/2 negative breast and ovarian cancer patients from Pakistan. So, breast cancer is the most common malignancy among Pakistani women that account for about 28.7% of all female cancers in Pakistan. And there are several risk factors for this disease, including the genetic risk factors and non-genetic risk factors. Among genetic, the mutations high, moderate, and low penetrance breast cancer susceptibility genes, and among non-genetic risk factors, hormonal and lifestyle factors are involved. So this is what about the pancreatic breast cancer risk, genetic risk factors in Pakistan. The mutations in BRCA1, BRCA2, TP53, RAD51C, PALB2, and RECQL gene account for about 27% of all familial and early onset high-risk breast cancer patients, whereas the genetic risk factors for about 73% is unknown. So Fanconi anemia complementation group M, that is FANCM, may be a plausible candidate for this missing inheritability. So FANCM is located on long arm of the chromosome 14. It contains about 65 kb DNA and 23 coding exons that code for about 2000 amino acids and 232 kilodalton protein. There are several functional domains, of which the MM1 and the ERCC4 are very important for the DNA interstrand cross-link repair through homologous recombination. So FNCM was first reported in Finnish population in 2014 as a breast cancer susceptibility gene, and a founder mutation, that is a nonsense mutation, was identified, particularly in triple negative breast cancers. And deleterious mutations in this gene confer about 2 to 4-fold increased lifetime risk of breast cancer for the carriers. So no data of the prevalence of this gene is available among Asian. And we screened this nonsense mutation, that is a Finnish founder mutation, and no mutation was detected among 117 TNBC patients, whereas 2 other missense variants were identified. That prompted us to whole gene screen in our population. So the study objective was to assess the prevalence of germline FNCM variants in early onset and familiar breast ovarian cancer patients from Pakistan. So total 201 breast and ovarian cancer families were enrolled in the study. Of these, 152 were female breast cancers. Of these, 96 were early onset and 56 were familial breast cancer. And 25 families were breast and ovarian cancer. 1 was male breast cancer and 23 were ovarian cancer families. And of these, 125 were TNBC and 41 were non-TNBC. Of all these 201, 46 patients have family history of hematological malignancies. And 200 healthy controls were also screened for the potentially deleterious variants in this study. After informed consent, blood samples were collected, DNA was extracted and quantified, and PCR amplification was performed for coding and in exon and tone boundaries of complete gene. And mutation analysis was performed by denaturing high performance liquid chromatography and then followed by DNA sequencing. The potentially deleterious mutations and novel variants were analyzed by in silico tools. For missense variants, several in silico tools, Polyfen2, SIFT, Panther, SNAP, Go, and SNAP2, and these were used. And for intonic variants, supply site finder, Max and Scan, and then supplies, gene splicer, and human supply site finder were used to obtain the deleterious score or benign variant. So this figure shows the DHPLC analysis chromatogram. Along x-axis there is a time, along y-axis there is a millivolt in the that shows the intensity of the DNA. The green peak shows the wild type DNA sample, whereas 2 peaks are shown for the mutant. And this figure shows the DNA sequencing chromatogram of the forward strand. There is a clear G peak that is a wild type, and there are 2 peaks overlapping for G and A. And this figure shows the DNA sequencing chromatogram of the reverse strand. There is a single peak for C wild type, and there are 2 peaks overlapping for C to T variant. And this variant was classified as a missense variant. So in total, we identified 19 coding variants. Of these, 1 was novel. All other was previously reported in the ClinVar databases or in other populations. And 1 was deletion insertion variant. All other were missense variants. And 2 variants were classified as variants of unknown significance, whereas all other were classified as benign variants. This table shows the non-coding variants. Total 17 were identified. Of these, 5 were novel. These are specific to Pakistani population. And all were reported, all was classified as having no effect or benign variant. The novel or previously unclassified variants or variants of uncertain significance were analyzed by in silico tools, 8 coding variants and 9 non-coding variants. Of these 8 coding variants, 1 was classified as variant of unknown significance. Of the 9 non-coding variant, 1 variant, that is insertion deletion variant, was classified as deleterious 1. So this figure shows the DNA sequencing chromatogram of the deletion insertion variant. There is a deletion of G nucleotide and insertion of 10 nucleotides. And we were expecting that this variant may have a splicing effect. Messenger RNA was isolated from the carrier. And then after performing the cDNA, the agarose gel electrophoresis was performed, and there is no extra band except there is a 401 base pair that is equivalent to wild type. And DNA sequencing shows there is no splicing effect and there is no extra band or extra variant, splicing effect on this variant. So this variant was classified as VUS. So in our population, 1% the variant was detected, VUS were detected on all families. The VUS were detected among 1.3% in female breast cancer and 1% among early onset breast cancer and 1.8% among hereditary breast cancer. No variant were detected in breast ovarian cancer, male breast cancer, or ovarian cancer. Among TNBC patients, 0.8% of the patients carried this VUS, and 2.4% among non-TNBC. No variant was detected in a healthy control. Whereas those families having hematological malignancies, 2.2% carried this variant. This is the pedigree of the missense variant carrier. There is a 3-generation pedigree. The circles are female, squares are male, and diagonal slash indicates a diseased individual. And this variant was identified in the Punjabi ethnic patient that had a grade 3 invasive ductal carcinoma and showed a triple negative breast cancer phenotype. This variant was previously reported in breast cancer patient from Spain, ovarian cancer patient from Australia, and esophageal cancer patient from Iran. So we classified it as a variant of uncertain significance. So this is the pedigree showing carrying the deletion insertion variant. And this variant was detected in 45-year breast cancer patient having a family history of Hodgkin lymphoma. And this patient was grade 2 invasive ductal carcinoma and non-TNBC phenotype. So this variant was classified in ClinVar reported as variant of uncertain significance. So in conclusion, no pathogenic or likely pathogenic FANCM were detected. The VUS were detected with 1.8% among familial breast cancer, 1% among early onset breast cancer, and 0.8% among TNBC, and 2.4% among non-TNBC. And the variant was also identified with prevalence of 2.2 among those having hematological malignancy. So in conclusion, a marginal contribution of FANCM variants to early onset and familial breast ovarian cancer patients from Pakistan. So we are grateful to the study participants, clinicians, and study coordinators, basic sciences research team who was involved in this research, and our collaborator, mentorship, and funding. We published this study in familial cancer this year. Thank you very much.
Thank you very much. Is there any question? So if there is no question, then we'll move on to the next speaker, Dr.
I think there is one question
okay.
in the audience.
Yes, please.
If the insertion deletion variant is classified like deleterious through different rules, then how can we say that it is variant of uncertain significance in this population? So
Okay, basically the insertion deletion was detected as as deleterious by all the in silico tools, but in co-segregation analysis in the pedigree, you can see one of the affected individual did not carry the mutation, whereas the affected individual carried this variant. So there was not a clear co-segregation of this variant in the pedigree. On the basis of contradictory results, we classified finally it as a variant of uncertain significance. I think this is the answer. Thank you.
So our next speaker is Dr. Amna Khan. Here. Okay. Mohammed Adil Kamar. Asim Farooq. So now we have 8 minutes for the talk and 2 minutes for the question and answer. Asim will talk about the clinical characteristics of COVID-19 infected cancer patients in Pakistan, differences between survivors and non-survivors.
Assalamu alaikum, everyone. I'm Asim Farooq, and I'm a clinical research officer at Shaukat Hospital, Lahore. And today I'll be talking about clinical characteristics of COVID-19 infected cancer patients in Pakistan and the differences between survivors and non-survivors. So, as we all know, the coronavirus disease of 2019 is caused by the severe acute respiratory syndrome, coronavirus 2. The virus was first detected in December 2019 in Wuhan, China. The whole world, including Pakistan, experienced COVID-19 outbreaks. So for cancer patients, there's an increased risk of opportunistic infections due to impaired immunity, poor nutrition, and post-cancer therapy associated side effects. Studies conducted by several research groups demonstrated that cancer patients with COVID-19 had poorer outcomes, showed poor prognosis, and were at a higher risk of high risk population with an increased mortality rate. So let's talk about cancer incidence in Pakistan. Each year, around 200,000 new cancer cases are being diagnosed in Pakistan. And the top three of these are breast cancer, lip, oral cavity cancers, and lung cancers. And as we can see, the data provided by Globocan in 2018. A fraction of these cancer cases are treated at Shaukat Hospital. So we reported systematically characterized clinical features of survivors and non-survivors from Pakistan in an attempt to define the nature of aggravating factors caused by COVID-19 infection. So this was a retrospective cohort study. COVID-19 patients were diagnosed on the guidelines provided by WHO. All patients had previously been diagnosed with cancer. We included all patients with pathological diagnosis of any malignant or solid or hematological malignancies, along with PCR confirmation of SARS-CoV-2 infection. The Institutional Review Board of Shaukat Hospital approved this study, and the demographic data, clinico-pathological characteristics, pathological and radiological findings were acquired from hospital's medical record system. Let's talk about the results. So around 13,700 patients were diagnosed with COVID-19 infection at Shaukat Hospital between April 13 and July 19, 2020. So among these, 443 cancer patients which were registered with the hospital, and they were diagnosed with the COVID infection. And so we had to exclude 362 patients because they were not hospitalized, being that they had mild or very low symptoms of the COVID-19 infection. 81 cancer patients were included with COVID-19 symptoms that were admitted at the hospital. And among them, 11 patients were then again excluded because they were aged below 18 years of age. So total study population which we had was 70 patients with a history of solid or hematological malignancies that were included in this study. So 54.3% patients were male and 45% patients were female. The overall mean age was 50 years. Along with cancer, patients had other comorbidities like diabetes, hypertension, chronic pulmonary disease, chronic kidney disease, coronary heart disease, and chronic liver disease. So as of July 9, 2020, 42.9% of the study population had died. So this is close to 50%. And the primary cause of death was COVID-19 infection for these patients. So approximately 2/3 of these patients were admitted to hospital within 24 hours of diagnosis. And the main symptoms were dyspnea, cough, and fever, while muscle ache, sore throat, diarrhea, vomiting, chills, abdominal pain, and headache were sort of less common symptoms. Talking about cancer history, 57 patients had solid tumors and 13 patients had hematological malignancies. More patients had advanced stages of cancer, stage 3 and 4, and almost 23 patients had metastasized cancers. So the time since diagnosis was 23 patients were diagnosed in the previous year, and 36 patients were diagnosed in past 5 years, while 11 patients had been diagnosed for more than 5 years. Complications that were associated with these patients were acute respiratory distress syndrome, acute renal failure, septic shock, abnormal liver function, coagulopathy, secondary infection, and arrhythmia. And all of these had a significant effect on the mortality of the patients, as we can see that non-survivors had the more complications, and that was significantly associated mortality. Further results, there was significant difference in oxygen saturation among survivors and non-survivors. The respiratory rates were also different between survivors and non-survivors. We observed higher neutrophil count, C-reactive protein, lactate, ferritin, aspartate, aminase, creatinine, blood urea, nitrogen levels in non-survivor patients as compared with the survivor patients. So radiologically speaking, we found bilateral lung lesions in 70% of the data in our data set, which was higher than all other reported data sets at the time. So this suggests that the cancer patients are more prone to severe pulmonary disease after COVID-19 infection. Furthermore, we observed that non-survivors were significantly more likely to receive oxygen therapy, require mechanical ventilation, and be referred to ICU. The most significant of our result, which was independent risk factor for mortality, was the D-dimer levels. So higher D-dimer levels were seen by several studies in COVID-19, and they associated